Dr. Ravish and Dr. Kirtish to log in.
Good morning, Deepak. Am I audible?
Hi, Deepak.
Hi, sir. You are there, I saw.
Yeah, good morning, Deepak and Ravish sir.
Good morning, Kirti.
Good morning, sir. 2 minutes, sir. I'll start.
Yeah, no problem.
Sir, good morning to all of you.
Oh, good morning, sir.
Good morning,
Good morning, sir.
Hi, Dr. Kirtish.
Hello, sir.
Kirtish, I will be leaving after first presentation. I have another webinar.
Okay,
Kindly continue.
no problem, sir.
Okay.
Sure.
Okay.
Shall I start?
Sure.
Sir, I request Dr. Ravish sir and Dr. Kirtish sir to share your screen whenever you're talking. Okay.
Okay.
Yeah.
Good morning, all. Happy Mental Health Day. Mental Health Day yesterday with an apt theme for this year: mental greater investment and greater access. 2020 has been a crazy year with COVID-19 pandemic, which has brought a sea of challenges together. Be it healthcare worker, difficult circumstances, fear of taking COVID home, for students exams getting postponed over and over again, and they have to be content with online classes with no social activities to look forward to. It has created a lot of anxiety about uncertain future. Most plans, projections, strategy, market, travel plans, growth trajectory, etc. have gone haywire, causing significant distress to every ranging from financial, social, spiritual well-being of whole human race, cutting across boundaries. Was rightly called psychological time bomb. As expected, it has increased the prevalence of psychiatric morbidity multifold, with hardly much funding or resources to contain the mental health issues, with most allotted fund being diverted to COVID care. We see year after year our colleagues doing quite a bit of awareness programs on eve of Mental Health Day. It is promising and definitely fruitful. Who else will speak about mental health other than us? There is a significant stigma regarding mental health in our country, and it will remain so for quite a few years to come. Only way of eliminating stigma is by creating awareness about mental health at all levels of our society. We can take a clue out of COVID crisis, how the information propagated by the government in multiple mediums empowered general public to be warriors in educating people around them and helping us control the damage. In fact, COVID-19 is not only a pandemic, but it is an infodemic. I appeal to all psychiatrists, IPS, KC, office bearers, and mental health professionals to dedicate one day a week for mental health awareness. One day a year is simply not enough. We can build knowledge about mental health to all sections of society, propagating information mental health on throughout the year. Let's help people to nurture their mental health and build a happy nation is bound to progress in all fronts. Now, I would like to introduce chairpersons for today's sessions. Dr. Ravish BN, Professor and HOD of in the Department of Psychiatry, Mysore Medical College. He is also a past president of IPS KC. We fondly call him Singam of IPS KC. The second chairperson for the day is Dr. Kitish. He is currently HOD and professor at Department of Psychiatry at BGS Medical College. Over to you, Dr. Ravish, sir.
Thank you, Deepak. Welcome to all the IPS KC members and to the co-chair. At the outset, I thank the organizers of eKANCIPS, Chitradurga, for giving this opportunity. Today is the second day of eKANCIPS, and wishing you again the World Mental Health Awareness Month. Now, this session is focused on addiction, and we have three speakers. First, Dr. Narayan Mutalik, then Dr. Praveen, and then Dr. Satish Ramaya. Dr. Narayan Mutalik will be speaking on dual diagnosis with regard to addiction, the newer trends and emerging advances. As you all know, Dr. Narayan Mutalik served recently as treasurer of Indian Psychiatry Society, Karnataka chapter. He is associate professor at Nijalingappa Medical College, Bagalkot. He did his MBBS from Jawaharlal Medical College, Belgaum. Then his MD from prestigious NIMANS, Bangalore. He is definitely an asset to IPS KC and then probably future to zonal and national level. He has won many laurels, both national and international level. His focus is on psychosexual health. He has published more than 16 articles. He's co-authored many books. So without wasting much time, I request Dr. Narayan to present his paper. Over to Narayan.
Good morning, everyone. At the outset, I would like to thank the organizers of eKANCIPS 2020 for giving me an opportunity directions. First of all, before going to the topic proper, I would like to declare that relating to this presentation, there are no relationships that could be perceived as potential conflict of interest. So, coming to the definition, actually the dual diagnosis is traditionally defined as the co-occurrence of substance use disorder in patients with severe mental illness that is schizophrenia and bipolar disorder. But in recent times, the notion of dual diagnosis has been expanded and used interchangeably with the comorbid or co-occurring disorder illness along with substance use disorder. So comorbidity is the temporal coexistence of two or more psychiatric disorders as defined by the ICD, one of which is problematic substance use. So WHO says the co-occurrence in the same individual of a psychoactive substance disorder and another psychiatric disorder. As you can see here, the disorder and another psychiatric disorder, which can occur simultaneously in the same individual. So we have many terms which can denote this dual diagnosis, like mental illness and chemical abuse, chemical addiction and mental illness, co-occurring addictive and mental disorders, substance abusers with mental illness, mentally ill substance abusers. So nearly 45% of the individuals with substance use disorder have a coexisting psychiatric disorder, and of these 17.5 million population, this study was done in America. So 8% of the adults have experienced a serious psychiatric disorder in the past 1 year, and of substance use disorder. As you can see here, based on the statistics, nearly 28% of the people with the severe mental illness have substance use disorder, and in the same way, the nearly some 16% of the people with the substance use disorder have severe mental illness. So this is the one study which was done in India. So it says that 32.4% of the population have this dual diagnosis. As per the National Comorbidity Surveys and ECA, they indicated that the rates of comorbidity among the persons who are treated mental health services are even higher than those in the community. This is due to the what we call Bergson's bias. That is, persons with more than one disorder have an increased chance of being treated, and the symptoms of comorbid anxiety and affective disorders are more likely to seek the treatment. So as you can see this chart, 6.8% of the population fall in the age group of younger age is a vulnerable group. So do we have any other vulnerable population for this dual diagnosis? Yes. Another is family history of substance use disorders and female gender, combat exposure, and the history of childhood abuse. See, uh, we have several models of comorbidity so that which can establish the reason for the dual diagnosis. One is common factor model. So here the substance use disorder may represent two or more independent conditions. And second is secondary substance abuse model, wherein the psychiatric disorder other than substance use disorder is a risk factor for drug use and the development of a comorbid substance use disorder. Third is secondary psychopathology model, where the substance use disorder could trigger the development of a psychiatric disorder in such a way that additional disorder then runs in an independent course. And lastly, it is a bidirectional model. The temporary psychiatric disorder is produced as a consequence of intoxication with or withdrawal from any kind of substance, specific type of substance, also called as substance induced disorder. Model, how are you going to establish this? So common factor models, they posit that higher rates of comorbidity are the result of this shared to both the disorders. First, within the individual family members, genetic vulnerability to one disorder illness could also be associated with substance use disorder, with the offspring at increased risk to developing either or both the disorder from the genetic contribution of that individual parent. So, and associative mating. If the family members with one disorder, say severe mental illness, were more likely to mate individuals with the other disorder, like substance use disorder, then there would be, which could be expected by chance alone. This is called cross-trait associative mating. The offspring would be and developing either or both the disorders due to the individual genetic contributions from each parent. And second being the causative factor antisocial personality disorder, which increases the rate of substance use. And other two factors being the impairment in cognitive functioning and this lower socioeconomic status, both predispose a person for substance use disorder and severe mental schizophrenia. So such impairment could reflect genetic factors and early environmental factors or a combination of both. So coming to the secondary substance use disorders model, here what we have is a self-medication model. Self-medication denotes that the individual seeks specific substances to alleviate particular painful effects. And next time being the alleviation of dysphoria model, which represents a more general model than self-medication, and it indicates that the people with severe mental illness are prone to dysphoric experiences that make them also prone to use the psychoactive substances. They are considered to be like others with substance use disorder in that they initially use substances either to feel good or to alleviate the feeling bad before the process of addiction supervenes. And there are multiple risk factors like social isolation, school and vocational failure, poverty, and lack of adult role responsibilities, lack of structured daily activities, and association with deviant subgroups, and living in neighborhoods with high rates of drug availability. These are all the multiple risk factors which can increase the risk of substance use and also dual diagnosis. So, second entity being the supersensitivity model, according to which the psychobiological vulnerability, which is determined by a combination of genetic and early environmental, like perinatal events, they interact with environmental stress to either precipitate the onset of a psychiatric disorder or to trigger the relapse. So, in addition to the influence of stress on vulnerability, the psychotropic medications can also decrease the vulnerability, whereas substance use may increase it. Here we have secondary psychiatric illness model or secondary psychopathology model, wherein the entities, there are two entities here, behavioral sensitization and kindling. Animal research has shown that repeated or continuous stimulant administration can lead to increased sensitivity of the response or this behavioral sensitization. Increased electrophysiological and behavioral responses can be induced by repeated electrical stimulation or stimulant administration, referred to as kindling. And there are many other this behavioral sensitization and kindling due to the substance use have been suggested as mechanism by which the drug abuse may precipitate the schizophrenia or bipolar disorder. And there are many other studies like prospective follow-up studies of substance users, ways or alcohol use, and the development of psychosis or schizophrenia over a period of time. And there are studies of long-term psychosis following drug use with respect to the LSD or amphetamine, which mimic the schizophrenia. These studies of long-term psychosis following drug abuse, patients admitted to psychiatric hospital with prolonged psychosis following LSD, compared to non-substance use disorder patients with acute psychotic reaction, they tended to have better premorbid functioning, a different symptom profile, means more conceptual disorganization and excitement, less blunted affect and motor retardation and guilt, and lower pretreatment cerebrospinal fluid 5-hydroxyindole acetic acid levels. Now comes the bidirectional models, means it is largely theoretical and untested. Here the substance use disorder could trigger severe mental illness in a biologically vulnerable individual, which is subsequently maintained by continued substance use disorder due to socially learned cognitive factors such as beliefs, expectancies, and motives for substance use. These could be the reasons why everybody will ask you the question, does substance use cause psychosis or vice versa? So, coming to the neurobiology, see, there are multiple theories behind the causation of this dual diagnosis. One is ALDH2 polymorphism and alcohol dependence, and past or current history of anxiety, depressive disorder, or both. Another is NMDA receptor hypofunction in both the disorder. That's why we prefer to use eKANCIPS. And smaller prefrontal cortex and prefrontal cortex white matter volumes, and increase in glial cell densities in the anterocingulate cortex of alcohol dependent, depressed and suicide completers, and total gray matter volume deficits were shown. And and mesoaccumbens circuits in both the disorders. Blunting of means there is involvement of mesolimbic dopamine system. This nucleus accumbens mediated behaviors associated with both the disorders, and there has been elevated mono unsaturated N acyl ethanolamines in dual diagnosis patients. Biological entities which we come across in the recent studies. So having so first and foremost, the salient features means like severity of the dependence will be less, and they will have better perimorbid functioning and more positive in diagnosis, and they have more severe delusions and hallucinations and more depressive and anxiety symptoms. They will be more violent, and non-adherence to the medications is greater. And you should establish and you should inquire about the present and the past history of cravings for any kind of substances, and adherence to the treatment regimen history in relation to the substance use, and history of menstrual cycle, pregnancies, and contraception use in case of female patients. And again, we have current and past history of substance use patterns, and the quality of life, and present safety level. You should do the risk assessment, and current and past history of suicidal, past thoughts, intent or means or prior history, and treatment, and trauma history. So you have taken the history and all. There are several assessments. So this is a breath analyzer, which is usually kept in most of the de-addiction wards, so you can drink to the ward. And biochemical assessments with which you can have the fair or not, whether there has been recent use of alcohol based on GGT levels and SGOT, SGPT levels in blood. And there are several other screening instruments which will help you to assess the severity or some kind of hints like for substance and mental disorders, screening and brief intervention and referral to treatment, which is a voluntary process which requires the patients to be active participants. And it's an evidence-based approach used to identify, mitigate, and prevent risky substance use behaviors. So others are like of lifestyle instrument, audit, and cage questionnaire, which are pretty well known. To treat this, do you have any consequences when the person has both the disorders? Yes. There are high rates of hospitalization and depression, even among the neuroleptic compliant patients. And the suicide risk is more, even in schizophrenia, which was not associated with alcohol misuse or dependence. And higher rates of infectious diseases and higher rates of HIV, AIDS, and there is possibility of zero prevalence C virus. There will be increased violence. There has been some 2 to 7-fold compared with non-alcoholic subjects with schizophrenia, and also some amount of health harms like metabolism of medications in the liver can be adversely affected by alcohol abuse. And we have this tentatism for alcoholic subjects with schizophrenia compared with general population. Apart from this, we have like more impaired functioning across memory and reduction in the whole brain volume and exacerbated gait and balance deficits situations and prone for homelessness, and they have poor quality of life, and a recent substance use is a predictor for uh, poor adherence to medications. You have properly, but how do you want to treat it? So as we have the goals, our goal should be to reduce homelessness, reduce HIV, contain HIV infection, decrease severity of substance abuse, increase treatment participation, and to self-management of illness, and target the meaningful work, the friendships. There are 4 stages of treatment here. So initially we should build a trusting treating relationship, which is called engagement. The next is persuasion. It is nothing but developing more recovery. Active treatment means development of the skills and supports which are needed for illness management and recovery. And how do we have to achieve this? We have 3 models. One is sequential disorders are treated consecutively. The patient usually receive treatment for most serious problems first, and once the treatment is completed, they are treated for their other increased risk of dropout. So for that reason, evidence suggests that this model should not be used when dealing with the diagnosis patients. The next comes the parallel model, wherein the treatment of the two different disorders is undertaken at the same time with the drug and mental health services licensing to provide services concurrent. So the potential negative consequence being the lack of overall falls on the patient. So lastly, which is the most accepted, is the integrated model. The treatment is provided within a psychiatric or drug treatment service or a special comorbidity program or service. So the treatments include motivational, behavioral intervention, relapse prevention, pharmacotherapy, and social approach. It's a wholesome treatment. So initially, most so research anti-craving agents are in one or the other way useful in managing the dual diagnosis based on the which I explained earlier. So acamprosate, as we said, NMDA receptor dysfunction is some shared pathological process in schizophrenia and comorbid alcohol abuse. So, and it is known to improve the cognitive deficits in patients with dual diagnosis. And naltrexone, it is known for treatment of negative symptoms in schizophrenia and also treatment of tardive dyskinesia. So it is effective in a dual diagnosis when the patients have morbid substance use disorder. And ondansetron, it is particularly for negative and cognitive symptoms, and there is a possible role of enhancement of memory function in schizophrenia. And there are other anti-craving agents like topiramate and baclofen. Earlier reports say about the disulfiram, but higher doses in the studies, higher doses of disulfiram usually used to cause psychosis, but recent evidence say that disulfiram at a dose of 250 mg psychotic symptoms. And individual treatments, if you have to go, the depression and substance use disorders, here naltrexone and SSRIs have proven, and the recent guidelines by this European Monitoring Center for Drugs and Drug Addiction found that antidepressants have little effect on the maintenance of abstinence. So when an antidepressant is effective in treating acute depression, there is only a relative reduction in the use of psychoactive substance. So this is one of the studies where 60 young people received CBT and only 28 received standard care only. So those in the combination group showed significant reductions in the depression and cannabis use, and also there has been increased social contact and motivation to change the substance use at a 3 months follow-up. Substance use disorder, so two things we need to take into consideration. We have to explain, we should assess the level and the type of the substance misuse, and the patient should be warned about the potential interactions between the substance of misuse and prescribed medication, because most of the substances like nicotine itself will reduce the level antipsychotic level in the blood. And here also the guidelines say that combination treatment, that is integrated model, is useful. So to tell you the few words, typical antipsychotics usually we have to avoid, because they do not decrease alcohol or substance use in patients with schizophrenia, because they do not improve the functioning of dopamine mediated mesocortical links. and these are potent D2 receptor blockade, so they may worsen this dysfunction and further impair response to reward related stimuli. So atypical antipsychotics are and quick dissociation from the D2 receptors, and they are more effective in the treatment of negative symptoms and positively alter the mood, and they have positive impact on the cognition, and they have moderate affinity for 5HT3 receptors. So clozapine, it has got fairly good studies which says that it decreases the severe alcohol use disorders, and it is more effective in limiting alcohol or cannabis use than risperidone. And olanzapine, even is mixed, it is known to reduce the use of substance. Aripiprazole, it is known to decrease craving for alcohol, and quetiapine, it is equally efficacious in managing dual diagnosis disorders. So anxiety, SSRIs and SNRIs generally are considered first line treatment. Here also the combination treatment is better, and psychosocial interventions shown a positive effect. Personality disorders, they should be offered the same range of treatment options as Axis 1 disorder. So even though they have high risk behavior, and they should also be given treatment aimed at decreasing the impact of the personality disorder. So no evidence that any pharmacotherapy is particularly beneficial in the comorbidity of in the treatment of comorbid personality disorder and substance use disorder. In a 12-week RCT, 70 adults with a diagnosed ADHD and substance use disorder received either no significant difference in either the substance use pattern or the ADHD scores between the two groups, because both the groups had significant before and after decrease in ADHD scores. So another study said that there was significant improvement in clinician rated ADHD symptoms, but no improvement in self-rated ADHD symptoms and marijuana use when atomoxetine. And this is a meta-analysis which included 13 studies enrolling a total of 1,000 odd patients. It says that no beneficial effect was observed either on drug abstinence or treatment discontinuation. Nevertheless, a small to moderate reduction of ADHD therapy is recommended. Only psychoeducation on etiological commonalities and risks and sequelae of concurrent eating disorder behaviors and substance abuse, and dialectical behavioral therapy is effective in reducing. So we have been more focusing on pharmacotherapy of late for all kinds of dual diagnosis or kind of in the addiction, but we should focus on preventions. So this is the what we call as the strong disorder. So it is behavior, and it is most effective psychotherapy for children and adults. Dialectical behavioral therapy, it is designed specifically to reduce self-harm behaviors including suicidal attempts, thoughts or urges, cutting and drug use, and which is more so in case of borderline personality disorder. And multisystemic therapy which targets children and adolescents with substance use disorders such as attitudes, family, peer pressure, school, and neighborhood culture. Brief strategic family therapy. It targets family interactions that are thought to maintain or exacerbate adolescent substance use disorder and other co-occurring problem behavior such as conduct problems, oppositional behavior, delinquency, associating with antisocial peers, aggressive and violent behaviors, and other risky sexual behaviors. Comprehensive intervention for adolescents which focuses on multiple risk factors for substance use disorder and related comorbid conditions. Here, the families receive assistance with the juvenile justice system if needed. The treatment includes individual and family sessions. It addresses the adolescents' interpersonal and relationship issues, parental behaviors, and the family environment. Assertive community treatment. ACT is differentiates management through factors such as and outreach emphasis and highly individualized approach and treatments for severe mental illness such as schizophrenia and co-occurring substance use disorder. Now comes the therapeutic communities. It is a common form of long-term residential treatment for substance use disorder. So it focuses on the re-socialization of the individual, often using broad-based community programs as active components of the treatment. Here, the appropriate disorders such as criminal justice involved persons, individuals with vocational deficit, youth, and homeless individuals. In addition, some therapeutic communities may be helpful for adolescents who have received treatment for substance use and contingency management or motivational incentives. It is used as an adjunctive treatment. Voucher or price-based systems reward the patients who practice healthy behaviors and reduce unhealthy behaviors, including smoking and drug use. It is incentive-based treatments are effective for improving the treatment compliance and reducing tobacco and other drug use. Exposure therapy, it is behavioral treatment mainly for the phobias and PTSD that involves repeated exposure to a feared situation or object or any kind of traumatic event or memory. This exposure visualized or simulated. So it is always contained in a controlled therapeutic environment. The goal here is to desensitize patients to the triggering stimuli and help them develop coping mechanisms in the symptoms of anxiety, phobia. Integrated GUI, it is largely based on the cognitive behavioral therapy principles and is usually for patients with bipolar disorder and substance use disorder, designed to address emphasizes helping patients understand the relationship between the two disorders as well as the link between the thoughts and behaviors and how they contribute to recovery and relapse. Seeking safety. It is a present-focused therapy aimed at treating trauma-related problems, including PTSD and substance use disorder simultaneously. Patients learn here the behavioral skills for coping with trauma or post-traumatic stress disorder. A novel thing, mobile medical application, which was approved by the Food and Drug Administration at US in 2017 to help treat substance use disorder. Here the intention is for the patients to use it with outpatient therapy to treat alcohol, cocaine, marijuana and stimulant use disorders and not intended to treat opioid dependence. So, device delivery therapy to patients to teach the skills that aid in the treatment of substance use disorders and increase the retention in outpatient therapy programs as well. So finally coming to the end of my presentation, so I want to conclude by saying that there has been paucity of the treatment research in dual disorders across the world, more so from the developing countries. Both biologics contribute to this. Interrelationship is complex. Wide range of negative outcomes in this population exist, and atypical antipsychotics are preferred agents in the patients with comorbid psychotic disorders, and SSRIs in combination with anti-craving agents um, like sertraline and naltrexone combination were found useful in patients with major depression and alcohol dependence. And integrated and multidisciplinary approach with psychosocial intervention is a must for better outcome. Need to study various neurobiological aspects of dual disorders in greater detail. The study should include management is required. Thank you. Thank you very much for the patient hearing.
Yeah. Thank you very much, Dr. Narayan, for a very lucid and informative presentation about emerging trends and new directions in dual diagnosis of addiction. I think after the other two presentations, then there will be question and answers that will be taken up. So I request my co-chair, Dr. Kirtish, to take over for the further proceedings of the session. Over to Kirtish.
Sure, sir. Am I audible?
Yeah, your audio not visible, sir.
Is it? I shared my screen, so the video disappeared.
Zoom link which you have created, sir. Two pages of Zoom. Yeah, that one. Sir, start video on top.
Yeah, I started the video, but the video has disappeared from my screen.
Okay, fine. Do one thing. You do the proceedings. Audio is audible. The next
Okay.
session we'll set it.
Sure.
Be a little louder, sir. This, sir, you can start.
Yes. Thank you. Good morning and welcome to all the participants. I hope I am audible.
Yeah.
Yes. So I would like to thank the organizers for giving me an opportunity to chair the session. So next up, we will have two back-to-back sessions. The first talk will be on brain and addictions, the recent advances by Dr. Praveen Kerkar. So Praveen Kerkar is UG is from Nagpur, IG GMC, and MD from PGI Chandigarh. He has several collaborated research projects, including those with agencies like WHO and WPA. He has more than 50 scientific publications, including Travel Grant Award from UGC India. He is also the program director and coordinator for IGNO for the courses of family therapy for various psychological courses. And currently he is the professor and head for Department of Psychiatry in KIMS, Narketpalli, Hyderabad. The second talk will be on breaking the addiction cycle, pharmacological and psychological intervention. So this is by Dr. Satish Ramaya. So after completing his undergraduation from BMC, he went to UK to pursue post-graduation there. He completed his MRCP Psych, as well as specialized in multiple areas like liaison psychiatry, sleep medicine, and addiction medicine formally. So he has extensive work experience in the setups in UK. He has multiple scientific publications in reputed journals. He also has held several teaching and academic posts, like honorary lecturer in the Sheffield University, as well as head of academics in Cambian Group, UK. So currently he is the CAO, director and consultant in People Tree Marga Hospitals, Bengaluru. So after both of these sessions, we'll be taking the question and answers for all the three sessions together, as are all related topics. And over to you, Dr. Praveen Kerkar and Dr. Satish Ramaya.
Hello. Good morning, everyone. At the outset, I would like to thank the organizing secretary of the Karnataka Psychiatric Association for giving me this wonderful opportunity to talk about the exciting aspect and domain of the neuroscience and the potential of human beings in understanding as well as negotiating the blame, character, responsibilities, and so on and so forth factors which actually demonized and contracted the vision and created lots of stigma related to psychiatry. So when we wonder, is there any scientific method for transforming the inner world as such? And when the appreciation and potentials of the neuroimaging adds lots of weightage to our current understanding, and the empirical evidence keeps on growing, it all feels amazing to link between this mental activity and human brain function. So the compelling evidences are rising, and today we will like to see how the recent advances in the brain and addiction fields can actually help us understand this more depth. I remember there name was Valerie Dalrymple, and she tried to identify how the neuroimaging activity is being displayed when some emotions like love is being portrayed or analyzed. And she found the well harmonious integration of the subcortical region with the cortical region displayed on the fMRI signals. This is subsequently challenged to the implications that human values can also be displayed and processed in the brain to certain extent. That ventral stratum is one region which is responsible for the reward seeking, and ventromedial part of the prefrontal cortex along with the insula is responsible for analyzing, evaluating, and finding out what is good choice in our life. And when they blend together, a glorious expression of friendship where the opportunities of taking the drags, celebrations, either in a calm manner or an impulsive manner or a regressive manner, continues to happen. So in the present scenario, I would like to discuss some stages of addiction biology, the fundamental processes, neural pathways, connectivities, control, couple of decades. And then we will also see as well as the animal model plethora of insights which has actually helped in improving the treatment outcomes of the addictive disorders. Per se, this particular presentation is not related to more or less. We'll talk about the general consensus and the general understanding of how the addictive process actually develops. More or less, we know that most of the models in addictions are based on the bottom-up approach. But if we see how the environmental cues in natural processes are happening in and around, we see most of the natural rewards as well as drug rewards follows the neurocircuitry, either from dopamine or glutamate or maybe combined process, and some activation of the protein kinase pathways through cyclic AMP and calcium intracellular signaling happens, and some kind of neural plastic changes happen. So even now, this National Institute of Drug Abuse agrees that addiction is a brain disease. If we see those processes of addiction, right from acute reinforcement to compulsive dependence, withdrawal, protracted withdrawal and recovery, and then again, perhaps relapse and happening again and again, this cycle is typically divided into three bottom-up approaches. The first stage here, they usually starts with the persistence desire, which is then leading into binge intoxications, and then perhaps tolerance, and then comes the withdrawal and negative effects and stress responses. And this withdrawal perhaps then again leads to the preoccupation of obtaining more and more drugs, and then you anticipate. So this particular approach is very well discussed and found to have lots of emphasis of how the connections between the brains are perhaps deciding them. But when we think about a brain being hijacked by the drug, usually we understand that some individual who try the drug for the first time, say for example, 32% of nicotines being taken first for the first time, they'll likely to take again. For example, 23% is for opioids and heroines, and almost 15% of individuals who test the alcohol for the first time, they are likely to take it again for the second time. So basically, what particular mechanisms are there for explaining the drug craving? And one of the fantastic paper in 1993 from the Cambridge, which was published in the Brain Research, they advocated an incentive sensitization theory. And this theory reflects that when an ordinary stimulus of the drug is presented to the brain, what brain does, specifically the dorsal part of the basal ganglia, it processes the stimulus and it gives the stimulus memory to the prefrontal cortex. And when this ordinary stimulus is being silenced for a while, it gives it's a meaning for more attractive and wanted perception. And this psychological transformation process keeps on rumbling around, ruminating in the brain, and over a period of time, the same stimulus produces craving. Now, we see this model is being explained based on these three basic regions of the brain. The prefrontal cortex is considered to be the bridge of the sheep, which usually decides whether we should take the drug or we should take more time and avoid the aversive stimulations of the drugs. But the stimulation to the prefrontal cortex happens from a motivational engine, and that motivational engine is understood to be a region of nucleus accumbens. And from there, the control over the prefrontal cortex is gradually begins. This motivation engine is also supplied with lots of dopamine from the ventral tegmental area. And this ventral tegmental area is situated in the midbrain. So you can see these three brain region actually determines the cycle, a vicious cycle, which keeps on linking with each other. It feeds to each other, and it involves a discrete variations in how the people progress through the cycle and with the intensity with which they experience each of these stages. So basically, it starts with positive reinforcement, which means the drug, whichever is taken, is used for gratification or for pleasure, and this positive reinforcement is very closely linked with the impulsivity. This positive reinforcement then subsequently goes to the negative reinforcement, which is usually being perceived for relief of stress or relief of anxiety, and negative reinforcement is being parallelly analogized with the compulsive pathways of the brain. So if you see, ventral part of the brain is more or less related with the positive enforcement. Dorsal part of the brain is related with the compulsive mode of taking the drugs. Now, ventral part and dorsal part, there is a gradual shift over a period of time, and this shift is happening sometimes very fast with certain drugs. Sometimes it will take more time, as it happens with alcohol or nicotine. So this impulsivity can have a waiting period. It can be prematurely responding or risky impulsive choices. And the choices is being determined by either the direct, indirect, or hyperdirect ganglia. They will have three different pathways impacting through the caudate lobe, through the globus pallidus externa and globus pallidus interna. Now, these hyperdirective pathways, they have a tendency to decide for this particular timing of a person to choose and go for a drug. The intensity of these responses are gradually happening from the shift related with the quantum of the dopamine secreted, and this dopamine in turn takes the control from the dorsal region to the ventral region. And this happens through the associative learning of the channels. So in addiction biology, in 2019 November, there is a paper entitled Shift in the Functional Topography of the Frontal Cortex Striatum Connectivity. So we can see that over a period of time, the connectivities pathways from the ventral to the dorsal side of the brain is being shifted. When we analyze the connection between the frontal lobe, specifically the orbitofrontal lobe, and the striatal nucleus, we see that medial orbitofrontal cortex is associated with the positive reinforcement, whereas lateral orbital cortex is associated with negative enforcement. And the persistent structural modifications in the nucleus accumbens and prefrontal cortex actually leads to the plethora of problems of the continuations in the dependence process. So if we just analyze once again, we take some drugs are being ingested, they will produce euphoria and they will stimulate the nucleus accumbens, and a feeling of wow will come from inside. Now these nucleus accumbens will signal to amygdala, and it will weigh the pleasure of experience, and individual will feel this is worth repeating it. Now this amygdala will signal to hippocampus, and hippocampus is going to remember this. So they have a context specific set of information, and from hippocampus the information will pass on to prefrontal cortex, specifically the dorsolateral prefrontal cortex, and prefrontal cortex will ask, should we try it again and make it possible? So the competencies and the pooling control for the breach, as I said, will continue to happen, and the choices between the level of the drug, the frequency of the drug, and the situation specific drinking patterns or the choice of the substances would entirely happens. And this is a competition between prefrontal cortex and the striatal system, and this is being reflected in some of the paper from the Nature Neuroscience. And in 1993, after in 2005, there was a paper of neural basis of addiction. So we'll see in very nutshell how the different regions of the brains are involved in the addictive process, so as to make the understanding slightly more easier. So hippocampus, we all know this particular region is responsible for the memory. So the cue dependent context augmentation happens in the hippocampus, and people will remember over a period of time like how we enjoyed, and those particular processes will then be forwarded. So a next time intake of the drug will be facilitated through this memory and learning from the hippocampus. And we have seen that the concentration of the orexin and the dopamine is being parallelly processed for developing the intensity of the synaptic potentiation. So when some drugs, say for example, cocaine, in one of the published in the Addiction Biology 2020, reflects that when the concentration of the dopamine actually overtakes the orexin, then the subsequent potentiation of the hippocampal synaptic potentiation happens, and they went on to take the drugs more and more. Now, there is another region, if you can see, this is the insula. The insula is a beautiful region which actually thinks of oneself. It identifies how uh, how particular conventional ideas inside the human mind is reflected, and how much we actually drink, and what are the different parameters which determines the reward process in the brain. So say for example, those individuals who would like to see that their nicotine withdrawals are going on, these nicotine withdrawals control is happening from the insula. And there are studies which try to evaluate if there are lesions of the insula, and when patients were trying to stop their dependence, it is very easy for them if they have the lesion of the insula, so they can come out of it, relative to the other individuals whose insula is very active. So this is one of the way for identifying the pathways of intervention. Now, this particular neuroimaging reflects that a low dopamine D2 concentration is actually responsible for the loss of control in the cocaine user. So you can see the PET scan, one middle figure of the brain 1 month after the cocaine use, very less concentration of the D2 receptors are seen. This is a raclopride assay of the dopamine receptors. 4 months after, you can see some dopamine D2 receptors are started happening. So actually, this particular study reflects that these individuals have lesser dopamine in their brain, and they have a biological need to take the drugs so that their dopamine concentration will keep on increasing. This region is subthalamic nucleus, and you can see the subthalamic nucleus has one of the highest level of connections with many more brain regions. And subthalamic nucleus helps in controlling the processes of cravings. It's the only area where it elicits the excitatory glutamatergic neurotransmitters in basal ganglia. So as I said, that there is an hyperdirect pathway from prefrontal cortex to the subthalamic nucleus. So this hyperdirect pathway responsible for taking the actions, whether you should go or you should take the control. So some people used to say that you have a free will, you can actually control yourself. Lot of motivational speeches or inspirational things are being given. Some loving characters will come and they will try to convey, don't go, don't do. So those kinds of interventions actually happens between the silencio process of subthalamic nucleus and the prefrontal cortex, mediating through the insula. So this is a caudate lobe, the green color body in the brain at this basal ganglia. We know that caudate nucleus is a part which is responsible for the reflexive action, the habit formation process. You can see the anterior cingulate yellow color band just over the corpus callosum and the posterior cingulate cortex. Now, anterior cingulate cortex is responsible for analyzing the aftermaths of an effect, the stress, whatever kinds of emotional stress are studied inside, and then how do you actually want to negate out of it. Some people will go on choosing the choice between it, and the anterior cingulate cortex will controls the emotional part and would like to give a signal to the dorsolateral prefrontal cortex, and the choice is being mediated. I would like to discuss one particular aspect of the drinking pattern, and that is a binge drinking pattern, which is affected by our circadian system. Now, circadian system, we know the rostral part of the uh, pontine and midbrain regions, and then thalamic nucleus. They are associated with maintaining of the circadian region along with the suprachiasmatic nucleus of the hypothalamus. So there is a differential expression of the change in the phospho people who would keep on working for more period of time, and then they will return back and they'll drink more. Some constant light intake. So they have actually analogized this experiment in the rats, and they found that yellow color reflects the constant light supply, the blue color reflects the shift work experimental patterns, and the red color is the control one. So alcohol intake is like a binge eating patterns, and the blue light where specifically the shift work are happening, they take more alcohol compared to the other two situations. We can also see that anticipating and receiving these particular dose dependent patterns of the drug is modeled through the various neuronal networks from amygdala to anterior insula, and from anterior insula to dorsomedial prefrontal cortex. Another region, very interesting region, and that is lateral habenula. Lateral habenula has the connections with the posterior cingulate cortex and the precuneus, as well as through globus pallidus and nucleus accumbens. It also goes to medial prefrontal cortex. So what this lateral habenula does is it has a potential to control the aversive stimulus which is being perceived by taking the drugs. So this habenular system plays the important role in mediating and encoding the aversive states. Numerous studies indicate that habenula is one of the regions that controls the decrease in dopamine neuron firing in the ventral tegmental area, which is associated with failure to receive an expected reward. Nicotinic receptors in the habenular and intrapeduncular systems, they are responsible for the nicotine withdrawal. So basically it controls the neuronal firing in the VTA. Now, when this habenular nuclei was evaluated to identify how the intake of the drugs reflects or impact on the associated mood changes, they have identified that the serotonin transporter proteins, the extracellular serotonin concentrations, which is there, is being immediately reduced in this particular part of the habenula, and therefore the concomitant mood disorders are very common in substance abusers. This we have seen that withdrawal effects typically happens from the extended amygdala, but what I need to share you with is this withdrawal effect is processed through many neurotransmitters like corticotropin releasing factor, dynorphin, and norepinephrine, and which produces lots of anxiety and stress deficit features. In extended part of the amygdala, if we see some monosynaptic and glutaminergic inputs, they modulate the anxiety, social deficits, and spatial memories. Another study which I wanted to focus here, that midbrain ventral tegmental area has the ability not only for reward processing, but also for emotions driving things. So midbrain affects the pathways which ultimately goes to the dorsolateral prefrontal cortex, and the specifically in the alcohol patients, they were analyzed by the emotional Stroop test, and they have found that alcohol dependence is associated with impaired control over the emotionally motivated actions. They are not able to control their emotions much. We can see that in many binge drinking early onset college students, there is typically increase in the volume of the nucleus accumbens, and this nucleus accumbens volume is being modulated by the fatty acid amide hydroxylase enzyme, which in turn is influencing the levels of the endocannabinoid. So we know, like, after taking certain quantum of the drugs, specifically the alcohol, we get a immediate high, and after that we tend to get a low shift in the mood. This low shift happens because of the reductions in the endogenous endocannabinoid levels after the intake, and this highest level of the endocannabinoids is reduced uh, in the region of nucleus accumbens. And therefore, many experts indeed have tried to identify which treatment can work. So one of the treatment we know is deep brain stimulations. Even we have transcranial magnetic stimulations. So nucleus accumbens is found to have a novel target for identifying how these addictive regions can be controlled using the repetitive stimulations. Not only the subcortical region, even cerebellum system is also found to be affected, and we have taken the examples of the cannabis users. So cannabis use in acute phase, we can see that the gray volume matter of the cerebellum is increased substantially. The cerebellar activity is also increased in the acute phase of drugs, but no increase in residual or chronic stage. Attention, memory, these are the parts where acute system is being influencing through the brain, and the decision making system is also hampered. Uh, Apparently it seems like multiple regions in the brains are involved. So for example, to enumerate once again, binge intoxications are modulated through the ventral and dorsal striatum, globus pallidus and thalamus. Withdrawal and negative effect is modulated by amygdala and ventral striatum, and preoccupation or anticipation is modulated through hippocampus, orbitofrontal and anterior cingulate cortex. Now, when some researchers try to appraise why certain drugs have very short time of action, while other drugs like methylphenidate have a longer half-life after taking it. So it's a neuroimaging SPECT scan analysis have shown that the intake of the drugs after 2 minutes, 4 minutes to 20 and 30 minutes, and in fact for methamphetamine they had done up to 90 minutes. So they have analyzed that there is an autoreceptor deactivation system. When somebody takes the drugs, the more the auto activation happens, the shorter the half-life would be there for the drug to act in the brain. So we can see that in methylphenidate, the relatively longer half-life compared to methamphetamine and cocaine. So actually these neurobiological studies helps us to understand many part of it. A very interesting paper published in the New England Journal of Medicine reflects the role of the neurobiological mechanisms, and they have mentioned that interoceptive pathways which actually integrate the autonomic and the visceral system and increases the awareness through the insula is very helpful in subsequently getting the drugs again and again and going for a craving. So these processes are being expressed through the early genes expressions of the CFOS and the ARC, which are being studied in detail now. We can also see that typically the advances in the neuroscience has helped to identify which neurotransmitters are being raised at which region. So you can, in the downstairs, we can see in the slide the spectral analysis of the MRI, and certain neurotransmitters can be measured using the biosensors which are prepared with the ultra thin enzyme layers, and they can sense the level of these neurotransmitters inside the synapse, and this will help this will again help us in future how additional processes in the interventions can be done. So as I said, like ventromedial prefrontal cortex expresses and the drug seeking, but how the particular pathway does this is through the activation of the phosphatidylinositol kinase 3, which is being expressed at the ventromedial part of the prefrontal cortex, and through these systems then the protein kinase get activated, and the subsequent diminishings in the control of the prefrontal cortex starts. So these models are being developed in the neuroscience, and these models are specifically happening from the local field potentials. So local field potentials are determined on the higher and lower frequency basis. One of the model is spike timing dependent plasticity. So when we see that the pre and post long-term potentiation are being weighed for the changes of happening in the brain, the modulation principle is that if the presynaptic neurons fires a new milliseconds after presynaptic neurons, so if the presynaptic neuron fires first, the connection between the neurons will be strengthened. And we using this particular model, the computational models are being developed. The mathematical computation of the local field potentials allows the study of the circuit functions and dysfunctions via various simulative models. So a couple of models like uh, spike neuronal model, this is third generation artificial neural network. Then this is an ISVIX model, neuron model, which is capable of producing many patterns of biological neurons. And based on the use of these mathematical computation models, the firing rates of different brain regions, for example, striatal, globus pallidus interna, and subthalamic nucleus and VTA, they have seen the differences in these firing rates even at few milliseconds. And these analyses have helped us in identifying the new mechanisms of coupling prediction errors and the utility of anticipations. Say, for example, one of the recent paper reflects how the adolescent binge drinking disrupts the normal trajectory between the prefrontal cortex to cingulate cortex and till the occipital region. So multiple areas, you can see their action potentials over a period of time, how they diminishes. And because they are able to identify these action potential synaptic modulations, they now understood that we can use certain neurochemicals like N-acetylcysteine, which can prevent the stress-induced augmentation of addictive use. We know a lot of individuals will relapse during specifically the stress. So N-acetylcysteine is actually helpful in them. Some individuals are asked to do some physical exercise, and physical exercise as addictogenic use is also a therapeutic actions for the drug caving, and it strengthens the synapse. And when we see the sex-specific responses between males and females, the equilibrative nucleoside transporter type 1 helps in negotiating the age-specific male gender-specific responses. So at the end, if we see the recent biological explorations and animal research, along with the artificial neural networks, cellular neural networks, and spike neural network models, they have provided an explicitly defined models in the neuroscience, which has helped in designing the specific treatment approaches in neuroscience. And I believe there would be a time when the links between mental activity and the brain functions will continue to flourish. And in the quest of exploring the operations of the mind, we would certainly raise the possibility of positive potentials in many individuals, and the plethora of changes in acceptance of the treatment will happen in near future. Thank you so much for your listening. Thank you.
Next up, can we have a presentation by Dr. Satish Ramaya?
Thank you, Dr. Praveen, for the wonderful talk. Now I request Dr. Satish Ramaya to deliver his lecture.
Hello and namaste. This is Dr. Satish Ramaya. I'm a consultant psychiatrist and sleep disorder specialist at People Tree Marga in Yelahanka, Bangalore. At the outset, I would really like to thank the organizing committee of Kancips 2020 and the office bearers of IPSKC for giving me this great opportunity. So the title of my topic today is Breaking the Addiction Cycle, Pharmacological and Psychological Interventions. And I'm going to be focused on the new trends, latest evidence based on the neurobiological aspects in determining the best treatment with the best mechanism of action for people with. And my colleagues have already spoken about the dual diagnosis, the brain and addiction. I think this is going to be complementary to those talks, and we'll take the questions at the end of. So I don't need to reiterate to my psychiatrist colleague about the cycle of change proposed by Prochaska and Clement long time ago. So any person getting into addiction goes through several stages. When they actually become addicted, the first stage they enter into is called pre-contemplation, or a stage of denial, wherein they are in actual denial of many negative impact of the substance use, like physical impact, the psychological, the financial, the legal, the impact on their family life, relationship, and so on. Then they move to a stage where they start to contemplate about this negative impact. Then they actually prepare themselves to stop, make decision, actually stop with or without medical help. That is action stage. Then they move into the maintenance stage where they don't use any substances. This is the critical stage where in some people it can definitely be a lasting exit. In some people they do relapse because the underlying factors responsible for their ongoing substance use over the years, if it's not been addressed properly. And this, of course, is going to be a downward spiral, this cycle. So it's important that we take a step back and understand the neurobiological aspects of this cycle and identify the actual targets of treatment, both from psychological and the pharmacological. Now, let's focus on some key issues of addiction. In Latin, it means bound to or enslaved by. It is true that people with addictions are enslaved by the substance they actually consume. Their whole thought process, the feeling and the behavior is driven by the substances. So the key important points in addiction is the continued use despite adverse consequences. Yes, there's a lot of negative impact happening in their life, but they continue to use it. They can't stop. Next, compulsive engagement or diminished control over behavior. There's an element of compulsion there to engage in this behavior. They lose control. Then the appetitive urge or craving. That's intense psychological and physical craving for the substance. Now, what's important and interesting to note is clinical, preclinical, and neurobiological data of various substances involved in addictions shows some similarity in the way they are mediated in the brain, and could be a very crucial information for us to determine the actual treatment and the way it is targeted. So that's going to be the focus. But before that, let's try and understand some key principles of treating a person with addiction. It has to be a client-centered care planning. Always try and understand the individual, the circumstances surrounding him in the context of his personality, life, family support, and all that, and come up with a formulation and a plan based on those needs. The treatment has to be holistic. It cannot be just some pharmacological treatment. Psychological treatment and therapy is very important. Occupational therapy, maybe family interventions, housing, and so on. Consider the cultural context of the person, include the diversity. Set the goals. It has to be smart goals. Specific, measurable, achievable, time-bound, and realistic goals. The important aspect is the intervention strategies. That's where the focus of my talk is going to be today. We'll talk in detail about the intervention strategies in a minute. Also focus on the risk management. Be aware of the risk the person poses to themselves or others, and take into account the strategies to minimize the risks in your care plan. Communication and liaison is extremely important. Good communication with the patient, with the families, with all the professionals involved is the key. Crisis contact for the patient when they're in emergency, very important. And all through the treatment pathway, promoting and enhancing engagement is very important. Developing the rapport and ensuring the patient is actually engaging in treatment consistently, continuously, and completes the treatment is very important, and of course constant monitoring. Now let's move into the breaking the cycle. How do we break the cycle? We all know that the person with addiction goes through the cycle several times. So let's look at a new paradigm in how do we break. So although there may be several similarities in manifestations of addictions of various substances in various people, like compulsion, for example, it's a common factor. But you need to understand there are many key differences in this addiction and the person involved. The aspects of tolerance, of withdrawal, the neuroadaptation of individual substance may differ from one person to another. Hence, it's very important for us to understand several key factors in the neurobiology, like the individual substance involved, the site of action on the brain, the mechanism of action, the individual endophenotypes or the manifestation in that individual, the social acceptability, availability. So all those factors, it's important that we understand, so that we, based on those factors, we can determine the best target and the best treatment with the best mechanism. Koob et al. In 2009 came up with this neurobiological stages of addiction: the binge intoxication stage, the withdrawal negative affect stage, and the preoccupation anticipation stage. Binge intoxication stage is basically tolerance. It's a down regulation of positive reward pathways. That is, increasing drug levels are needed to trigger the brain reward system through positive reinforcement. Like I said, in other words, tolerance. The withdrawal negative affect stage, user transitions to addiction and experiences negative consequences when discontinued. That is withdrawal through negative reinforcement. And lastly, the craving stage, characterized by exaggerated motivation for drug use. So these are the three main categories in the neurobiology posed to determine the treatment. Now, these are the areas of brain where these stages are mediated. Now, there are several theories proposed for neurobiology models of addiction. Motivational neurocircuitry functions tend to favor the most, and not just on the study of addictions, but also on the addiction vulnerability. So several studies have been done looking into the areas of brain that are mediated in the behavior of addiction and the addiction vulnerability. So the main area is the corticostriato-pallidothalamo-cortical loops, the main centers involved. Amygdala mediating the affective information, hippocampus mediating the contextual memory information, hypothalamus and septum mediating the homeostatic information, insula providing the interoceptive processing information, and cingulate cortices emotional regulation, cognitive control, and stress responsiveness. Now let's understand the development of addiction. It all starts with some hedonic experiences by the person, pleasure or whatever we call it, high, and then that leads to immediate positive reinforcement. That person would want to get that experience more and more, so that reinforces his drug-seeking behavior. Then it leads to several neuronal changes and neuroadaptation, developing tolerance, wherein the person may actually start experiencing withdrawal symptoms, the unpleasant experiences when they don't use the substances, causing some negative reinforcement in the behavior and continued use. And as the person moves forward in their journey, it becomes, the actual substance becomes less rewarding and more compulsive and habitual. So it's important to note that here both the positive and the negative reinforcements are involved, and simultaneously what's been also understood is there's a progression of involvement of ventral to dorsal corticostriato-pallidothalamo-cortical loops. Of course, repeated use and alterations of motivational neurocircuitry and dopaminergic systems is happening through the journey of addiction. This leads to some cognitive attempts to control. The person who becomes addicted is motivated by delayed negative consequences of use, leading to change in attitude and behavior. So the cognitive attempts to control is motivated by this aspect, and there is this top-down control of prefrontal cortex over subcortical processes, which provides motivation to engage in addictive behavior. So there is an attempt to control. However, the positive reinforcement and negative reinforcement linked to the environmental or internal cues, which is behaviorally so ingrained, resistant to change, and powerful motivational craving states, cause some problem. So it's important that we understand this aspect of behavior in a person with addiction when they try to actually control the behavior. So our therapy is essential to target strong learned association between drug use and immediate positive reinforcement and negative reinforcement. Like we saw in the previous slide, it's important that we select or devise the therapies to address these aspects of cognitive learning and behavior. So what are the treatment phases? Key treatment phases in addiction. Stage 1, detoxification. Stage 2, initial recovery. And stage 3, relapse prevention. So what happens in detoxification? So we all know the goal of achieving abstinence and yield safe reduction of withdrawal symptoms is the goal. So whatever substance the person has been addicted to, we focus on abrupt cessation and also addressing the withdrawal symptoms in a safe environment. Of course, this will definitely need a lot of pharmacological focus. Usually, a replacement substance with similar mode of action on a neurobiological substrate with a slower and sustained effect, like long-acting drugs. So behaviorally, it results in withdrawal symptoms made less acute and more prolonged and gradual. So we all use chlordiazepam oxide for alcohol, methadone for opioids, and so on for the detox. The next stage is the initial recovery. After the detoxification, we need to focus on the initial recovery, the goals of developing sustained motivation to avoid relapse. So, yeah, there is a heightened motivation when the person is actually stopping the substance and detoxified. So it's important that we focus on this motivation to be sustained for long. So it's important to incorporate the learning strategies to tolerate craving induced by external or internal cues. So learning several strategies. Developing new patterns of behavior, alternative patterns of behavior with alternative rewards, replacing the drug-induced reinforcements. And yeah, this may require sometimes external and structural controls like hospitalization, limiting the access, so and so on. This may involve long-term medication, which is used for detoxification, and maybe sometimes we have to augment that with other medication to reduce the mental and physical symptoms like treating comorbid anxiety and depression. The next stage of treatment would be relapse prevention. This has to happen over a period of sustained abstinence and developing long-term strategies to prevent the relapse. This is the most critical, most difficult stage of treatment. Like I already mentioned in the cycle of change, the maintenance phase is the most difficult because that's where you focus on the relapse prevention and focusing on the underlying factors for the person, why he relapses many times over many years. So that reason being the long-term brain adaptations. Several neurobiological changes and adaptations have happened over a period of time, and to sustain the abstinence, these factors need to be considered in determining the best treatment. The support system, like Alcoholics Anonymous, to maintain the new behavior developed during initial recovery becomes. There are several social processes which help as well, like they can improve executive functioning by enhancing motivation, reducing friction and stress. All the social processes of people and the behavioral aspects, lifestyle aspects of the person. They provide alternative rewards associated with the drug use. They provide external constraints, the family support, the medical support, and so on. They enhance cortically mediated executive control or addicted behavior. So all the social support and the behavioral aspects actually is mediated through executive control. However, there are some threats to recovery. Now, what happens in a person with addicted when he has gone through this cycle and successfully abstaining from the substance over a period of time? There's waning of motivation happening. There's attenuation of external and internal controls and revival of associative learning. Whatever hedonic experience he had with the drug use in the past, that sparks again. It comes to the surface again, and there is reduced motivation. The external threats could involve exposure to drug, people who using these like peer pressure, we call it, places or things associated with drugs, or internal threats could be enhancement of hedonic experiences or the dysphoric experiences due to stress which he wants to overcome as a negative reinforcer. Interpersonal conflicts ongoing in the family, comorbid mental disorders could also be some of the other internal threats to recovery. So all these aspects to really keep in mind in treating the person in a very holistic. So let's look at the targets and treatments for addiction. Now, what are the neural processes targets of treatment? Broadly divided into two: top-down interventions and bottom-up interventions. What is top-down intervention? Top-down intervention is focusing to change the cognitions and behaviors mediated by enhanced prefrontal cortical function and altered executive control. Whereas bottom-up, focusing on the subcortical processes, striatal reward pathways, and mediate dysphoric symptoms and learned association pathways that do not require cortical activity. Broadly, the current psychological and the behavioral treatments are stronger in changing top-down activity, whereas pharmacological treatment targeting mostly the bottom-up processes. Now, let's look at some of the behavioral therapies and targets first before moving into the pharmacological aspects. So the two main areas, the compulsive use despite negative consequences and despite the desire to quit. The two main areas are the excessive desire to use or craving and insufficient impulse control associated with neurocognitive impairment. So these are the two key importance to remember in determining the behavioral therapies. This is what leads to the compulsive use despite negative consequences. And there's enormous empirical evidences for some of the behavioral interventions we regularly use in addiction. For example, brief motivational model, contingency management models, and cognitive behavior therapy. So brief motivational model known to be highly efficacious and durable. It's a very brief, even if it's a single session of motivational interview. It's known to be as effective as lengthier and intensive approaches. It's even for pathological gambling and eating disorders, it's used, suggesting similar neural mechanisms. The exact and precise neurobiological mechanism is still unclear, but what's known is quite helpful, and it is also attributed to the professional consultation. So the very process of going through the professional consultation, the way it's delivered and received, makes it very efficacious. So the brain motivational circuitry in general and certain specific regions of brain for risk reward decision making, cognitive control, planning and executive function have been known to mediate in this brief motivation. Contingency management model is another very well known model based on behavioral pharmacology and operant conditioning. It works on immediate reinforcement of abstinence, and it's known to cause very easy and reliable interruption in substance use behavior. For example, the token economy, giving cash for patients providing drug-free urine samples. So very concrete rewards. And this also ensures a person engages in the treatment adherence, medication compliance, also results in better efficacy of medication. So this is based on the behavioral neuroeconomic model, delay or temporal discounting, which basically means a greater value for immediate rewards as opposed to the future rewards. So if you're going to give the patient the money right now for not engaging in such behavior, the value is very high. If you say I'll give you after a week or so, it may not work. So it's temporal discounting. So the later the reward, the less effective it is. So it is mediated through ventromedial prefrontal cortex activation. So CBT we all know very well, based on operant and classical conditioning, very effective in certain aspects of relapse prevention of addiction. It also has a good sleeper effect. Basically, even after completion of CBT course, the effect of CBT is little long lasting. So the multiple sessions and multiple focus involved in CBT makes it a little difficult to attribute the neuronal circuits in their mediation. So it's a little challenging to attribute them directly. So, for example, coping strategies in cue-induced drug craving is, is mediated in prefrontal cortex and anterior cingulate. CBT also involves learning alternative coping strategies through various mechanisms. One of such example is training visual perception learning, changes in default mode, like restful waking brain, attributed in effective behavioral and pharmacological treatment of nicotine dependence, is not so well proven in CBT, but it is attributed. Now, what's understood is between the people with addiction and the controls. If you actually look at the circuitry differences, there have definitely a huge change. So it can be safely said that CBT normalizes this neuronal circuitry involved in addictions, plus the sleeper effects of it also helps. So what's the future of behavioral therapy? We know what's worked so far, targeting on the cognitive, emotional, and behavioral domains and the neuronal circuits. There are several behavioral therapies that's proving to be efficacious, like novel cognitive remediation strategies, which involves repeated intensive exposure to computerized exercises to strengthen the executive functioning consistent with our neuroplasticity. It is known to improve cognitive functioning in substance users with the neuropsychological deficits, improves treatment engagement and outcome. For example, working memory training reduces impulsive choice measures of temporal discounting. There are other therapies like mindfulness-based therapies, comparably efficacious and measures of retention and abstinence, reduction of subjective biological stress responsiveness, and so on, particularly helpful in cocaine-addicted women as compared to men. It did show some white matter changes implicated in emotional regulation and cognitive control. There's also this imaginal desensitization in pathological gambling, where this controlled exposure to cues over a long period of time uncouples the cues and the behavior. The 12-step program, we all know, it induces several neuroadaptations. One such example is when you're trying to make up with people who you have caused harm to because of your substance misuse. It may involve changes in neuropsychiatry implicated in social reciprocity and moral decision making. Now, the pharmacological treatments and targets. So we've seen the psychological and the behavioral treatment targets. Now let's look at the pharmacological. So as we all know, in drug addiction, there's adaptive changes in multiple neurotransmitter systems like dopamine, norepinephrine, corticotropin releasing hormone GABA, and glutamate, etc. And dopamine attributed to the reward, opioids for pleasure, and adrenergic neurochemicals for excitement. So the classical pharmacological treatment is based on the reward system, normalizing the function through positive and negative reinforcement strategies. Of course, we have to target the individual vulnerabilities and cognitive function. These are the two aspects we have to bear in mind when treating the individuals, because these two may form a big confounder in treating patients in a very... So medication targeting the positive reinforcement, like drug reward. So it's basically based on the hedonic reward, hedonic experiences. So here basically dopamine is mediated through incentive salience or wanting of the drug, whereas the endogenous opioids, cannabinoids, and GABA mediated drug pleasure for the liking. So wanting and liking, wanting mediated through dopamine and the liking through mostly opioid receptors. So the approaches taken in medication targeting the positive reinforcement is the agonist approach, basically to substitute safer long-acting like methadone for opioid dependence, nicotine replacement therapy, and so on. And modafinil has been tried for cocaine as well, with strong evidence, and also it's known to act as a cognitive enhancer, improving learning, so which might help to modify the behavior. So there's this antagonist approach as well in medication targeting positive reinforcement, blocking the rewarding effects of drugs. Example, naltrexone as an opioid antagonist, buprenorphine is a partial antagonist in opiate addiction, naltrexone also used in alcohol addiction too. So varenicline, partial agonist of alpha-beta nicotine receptors and nicotine dependence, and more recently some immunotherapies or vaccines have been tried for cocaine, methamphetamine, and nicotine addiction, which basically antagonizes drug effects via pharmacokinetics. The antibodies actually sequester the drug in circulation and reduce the speed, so blocking the reward system. D3 receptor targets have been tried in cocaine addiction, both as an agonist and antagonist. So it acts as an agonist when there is a withdrawal of cocaine, and when there is a cocaine use, it acts as an antagonist by blocking the reward system. So that's a very interesting and promising medication targeting negative reinforcement of drugs, negative reinforcing effects of abstinence manifesting as withdrawals, craving, negative mood like anhedonia and anxiety. So there is increased norepinephrine in opioid and alcohol withdrawals, we all know, and which forms as a negative reinforcer for the person to use or keep using drugs. There is sensitization to drug cues called craving, and adaptive changes in dopamine, GABA, and glutamate. There's a reduction of dopamine in the reward circuit, which leads to anhedonia following abstinence. So examples: methadone, buprenorphine for opioids, nicotine replacement therapy, bupropion, and varenicline for to attenuate negative mood states, acamprosate for alcohol withdrawals, and craving. Lofexidine is used for opioid, alpha-2 adrenergic agonist. Propranolol also tried in cocaine users. Memantine is used in cue-induced craving for alcohol, and even N-acetylcysteine in cocaine and nicotine addiction has been tried in nicotine. Now, I mentioned earlier about considering some individual vulnerability factors, because it's important to note that only 17% of cocaine users, 15% of alcohol users, and 30% of smokers become addicted. So not everyone using substances gets addicted too. So what are those vulnerable factors? The one major vulnerable factor which is has proven to be very important to take note is comorbid psychiatric conditions like psychosis, neurotic disorders, and ADHD. 90% of schizophrenics smoke, or 50% abuse alcohol and drugs. And it's usually associated with poor outcomes. The psychiatric comorbidity mechanism, self-medication could be a mechanism to relieve symptoms and side effects, and have some common genetic and neurobiological factors that lead to high comorbidity. Common vulnerable factors are impulsivity, reward sensitivity, and cognitive moral deficits. So effective treatment of psychiatric conditions. Other individual vulnerable factors, the cognitive deficits, well established in alcohol, cocaine, methamphetamine, and cannabis users. It does pose challenge in treatment engagement and learning new behavior, higher rates of attrition, poor treatment outcome. So it's important to improve ability to learn, remember, and implement new skills. So several drugs have been tried to improve the cognitive deficits, like galantamine in cocaine users, atomoxetine has been tried, modafinil, amphetamines, and varenicline trials. So combined approach, both top-down and bottom-up, in two ways, like in a complementary way, efficacious way, or when each treatment is not effective alone, catalyze each other. So combined to catalyze each other. This approach also has been very effective in treatment of addiction. Examples: methadone with behavioral therapies, antidepressant and CBT in smokers, bupropion with group counseling, contingency management and tricyclic antidepressant in cocaine abusers, immediate contingency plans. So what's the future of addiction treatment? It's important focusing on targets and match that to the individual needs. Individual factors, genetic differences to take note of, endophenotypes like impulsivity, compulsivity, sex differences, stage of addiction we need to take into account. Of course, be aware of the complexity of each individual constructs. For example, within impulsivity, there may be different constructs we need to be aware. So a broad range of self-report, behavioral and biological assessments and neurocognitive assessments may help. Timing of the treatment, very important. If some personality has some impulsive traits, early treatment of those individuals, when they may lead to addiction. So there are developmental issues to be considered depending on the age of the person, neurotoxicities and neuroadaptation of drugs involved, genetic factors, individual factors, all should be considered. Studies in non-substance addictions, pathological gambling and obesity have shown similar neurobiologics. So we need to study them to determine the best treatment and policy strategy. So in summary, we all know addictions cause a substantial public health problem. Neuroscience methodologies assessing brain structure and function provides excellent opportunity to understand and improve treatment strategies, novel targets for treatments, tools to assess targets, identifying clinically relevant individual differences should guide selection of therapies in combination, in complementary or a synergistic way. Of course, we need to be aware of other confounders like effect of drug itself on the brain functioning may influence treatment response. So I'll end my talk here. Hope it was useful to look at the neurobiology helping us in determining the targets, the best treatment with the best mechanism of action. Thank you very much for patient listening, and I'll pass it to the organizers. Thank you.
Thank you to both the speakers, Dr. Praveen Kerkar and Dr. Satish Ramaya. The talk by Dr. Praveen Kerkar was truly informative. He touched upon the neurobiological basis of addiction and the changes that happen in the brain because of the substance use. Dr. Satish Ramaya touched upon how we can break the cycle, by understanding the neurobiology and by using of both pharmacological and non-pharmacological treatment methods. Together with the talk by Dr. Narayan Mutalik, wherein he touched upon the concept of dual diagnosis. I think all three presentations were excellent and highly informative. They will, help all of us to better understand the, individuals suffering from substance use disorders and help us make a tailor-made treatment plan so that we can help them with the best available evidence-based managements. So the, questions are welcome. So I think you have to either type it in the question and answer column in the on the screen, or anybody who can ask directly can definitely ask the speakers with their questions. So by the time the audience warms up and comes up with some questions, let me ask a question of my own. It's open to all the three speakers. I have come across certain studies or tests done by genetic labs. One of the example is data genetics. They do the genetic analysis and they come up with a very detailed, genetic prediction, like how much percentage of genetic risk we have for particular conditions. So apart from the physical medical conditions like cancer and other illnesses, they also mention addictions, especially alcohol and nicotine addiction, that a particular individual has some, X percentage of risk for nicotine and alcohol addiction. So how reliable is it? And can we use this genetic prediction to identify high risk population and to prevent addiction? So that is my question, open to all the three speakers.
Am I audible?
Yes, sir, you are.
Good morning. In fact,
good morning.
Yeah. See Dr. Kirtish and Dr. Ravish facilitating our presentations here. I think this question is something which is taking us from today to tomorrow. In the need of the hour, when we are identifying who guys are at more risk and how can we actually find out a more nucleoside specific attributions, which is actually promoting the programs of various proteins implicated in addiction. So if you see, there are as many as few hundred proteins which are implicated in identifying how the pathways of protein kinases gets activated. So one of the protein which I have mentioned is about the nucleoside equilibrate protein, which is coded from chromosome number 4. And if you take a kind of 100 people who are drinking alcohol for the first time and asking them how many of them would not like to go for a second process. So there are certain genetic mechanisms, and as you rightly pointed out, people in the various research labs are identifying which genes are modulating the which predominance of effect. So I think at this point of time, it is only at the preconceptional level. They are just linking it with certain less degree of penetrance. 100% of penetrance and heritability is not being established. And one of the main limitation for this genes would be genes are needs to be consistently shaped and processing the information in the brain, and we do not know how this consistency actually happens over a prolonged period of time. So it's like, a caterpillar changing into butterfly over a period of time, but we never know like when this transformation is going to happen and exactness of those processes. So it's wonderful to see that genetic is contributing to certain extent, but at the same time we have certain limitations for brain and mind for entirety for the gene surface. Thank you for a wonderful question, Kirtish.
Thank you, Dr. Praveen. So we have some questions here. So Dr. Saranya Devanathan wants to know, what about medical comorbidities, dual or triple diagnosis? I guess the question is directed towards Dr. Narayan Mutalik.
Yes, yes. Yes, sir. Hello.
Yeah, we can hear you.
Actually, yes, medical comorbidity, but to name a few, there are some of the people this quoted this triple diagnosis, but not exactly as a terminology as per in what the psychiatrists we know of. But medical comorbidities are more common than the psychiatric comorbidities. What I have read in the most of the literature, like most of the people come with some of the other stage of dysfunction. It can be stage 1, stage 2, stage 3. I mean, up to hepatic encephalopathy. So, what exactly with respect to triple diagnosis, Ranya Madam wants to know. I'm not getting it.
Okay, so
I want to know.
Yeah, thank you. So probably we should take it up with the other specialists when they are making diagnosis, medical diagnosis. Probably we should expect them to add on the psychiatric and the substance use diagnosis together to make it a triple diagnosis, which will help ultimately the patients.
Exactly, we have to have consultation with the neurologist or the physician or neurologist for that matter.
Okay, thank you, Dr. So Dr. Ajit Bide wants, he has a comment. I would like to emphasize that in psychological intervention, therapist variables are of great importance. Example, just being trained in CBT is not enough. So charisma, competence, commitment on the therapist's part are tremendously important. So, I would like to have Dr. Satish Ramaya, respond to that. The therapist variables in management.
No, absolutely. That goes without saying, Dr. Ajit, that is absolutely right. We all know the efficacy of the psychological treatment isn't depend on the transferences and the counter transferences mechanisms within the therapy. So it's extremely, just like we were talking about the variabilities within the substance user and the substance use, the mechanisms involved in the neurobiology. Of course, the person in front of you, the therapist, the way the person mediates. We actually saw one of the points I mentioned in the brief interventional therapy, the brief motivational therapy. There's a huge evidence that even a single episode of brief motivational interviewing, the effect will be very long lasting and is comparable with the longer therapies as well. So, and it also highlights that the therapist, the way the therapist delivers the treatment, the way it is received, forms extremely important. So I completely agree that transferences and counter transferences in the therapeutic model plays a very key role. So it's always highlighted that the building the rapport is the key factor in delivering the treatment. Sometimes we may not need a highly qualified psychologist. We psychiatrists ourselves can start off the brief intervention models.
Thank you, Dr. Satish Ramaya. Yeah, there is one question from Dr. Krishna KR. So what about the use of RTMS for addiction, and what does the current research say about it? So it's open to any of the speakers. RTMS for addiction.
I am not aware of any great evidence for RTMS for addictions. But I think going by the neurobiological basis, we have highlighted enough of the cognitive deficits in particularly the individual vulnerabilities we're talking about, which are very similar to the affective disorders. So in going by that theory of where the neurobiology is mediated in the cognitive deficits of the individual vulnerability, I think it should theoretically have a value, but I'm not aware of well-established evidence for the treatment of addiction yet.
Okay. Anything other speakers want to add?
Actually, there are some of the studies which never have developed alcohol dependence comorbid with the depression. then some of the studies have quoted that RTMS is useful, but not per se with respect to as a single diagnosis of alcohol dependence, whether it is a withdrawal or for maintenance of abstinence.
Okay, thank you, doctor.
Thank you.
Highlight here, people have not read more about the RTMS as such, and it seems to be a fantasy therapy made to the other guys of modality of treatment. But I tell you, in addiction biology, there is a paper in last August 2020, and it emphasizes the specifically the methamphetamine modalities of treatment, where the right brain of the human who are consuming is very actively involved. So what they actually do is they put the cortex, right-sided dorsolateral prefrontal cortex, they'll put the RTMS coil, and the low frequency stimulation between 1 to 20 hertz would be given the repetitive cycles of few weeks, that the cortex stability will be reduced period of time, and actually and the craving and impulsivity will be taken care of. So there are preliminary studies happening in these particular from 2012-13 to 2020, and the multiple meta-analyses have been conducted in RTMS now, and there is a robust module that we might see that over a period of time, some RTMS small machines might come, and people are being advocated to put those electrodes in between whenever they will be at risk of taking the drug, specifically in the cue-dependent or stress-dependent module, where your right-sided brain is more activated. Over to you, please.
Okay, thank you, doctor.
Yeah.
So I think if there are no other questions, then I would like to conclude the session. And again, I would like to thank the organizers for giving me an opportunity to be part of this first online Kancips. Over to you, organizers. Thank you very much, everyone.
Thank you, sir. Thank you, Dr. Kirtish, sir. I thank Dr. Ravi, sir, for chairing the session. I also thank speakers for the session, Dr. Narayan Mutalik, Dr. Praveen Kelkar, and Dr. Satish Ramaya. Thank you, sir. We will proceed to the next program, which is launch of IPSKC newsletter. Over to you, Dr. Aruna Ediyar.
Hi everybody, this is Dr. Aruna Ediyar, Honorary Editor of IPSKC. A very festive greetings to all of you. This is our 5th issue of IPSKC newsletter. Kindly go through the editorial and also the invited articles where our dear colleagues have written about psychiatry and psychiatry practice in times of Corona. This year's theme of World Mental Health resonates with Sarve Janah Sukhino Bhavantu, which is a purely Indian sentiment altogether. The theme for this year is mental health for all, greater access, greater investment for everyone, everywhere. ಈ ಘೋಷವಾಣಿ ಅತಿಶಯೋಕ್ತಿ ಎನಿಸಿದೆ. ಎಲ್ಲರಿಗೂ ವಾಸ್ತವದಲ್ಲಿ ಮಾನಸಿಕ ಆರೋಗ್ಯ ಸರ್ವವ್ಯಾಪ್ತಿಯಾಗಿ ಎಲ್ಲರಿಗೂ ದಕ್ಕಬೇಕಾದರೆ ನಾವು ನೀವು ಮನಸ್ಸಿಟ್ಟು ಕೆಲಸ ಮಾಡೋಣ. ಆ ಸ್ಫೂರ್ತಿ ನಮಗೆ ಯಾವತ್ತೂ ಇರಲಿ. ಲಾಂಗ್ ಲಿವ್ IPSKC. ಥ್ಯಾಂಕ್ ಯು.
Thank you, madam. Now I call upon Dr. Gopal Das to moderate the next session. Over to you, Dr. Gopal.
Everyone, thank you, Dr. Deepak, for a successful first session. Now I would like to call upon the chairpersons for the second session of our scientific programs, which consists of 3 lectures. And first chairperson, I would like to call upon Dr. Harisha Delando Pettu. And the second chairperson, Dr. Suresh Balamat. And of course, both of them hardly need any introduction, but still for some facts. Firstly, Dr. Harisha Delantapettu, sir has completed his MBBS from MMC 1992 and MD Psychiatry from Bangalore Medical College in 1998, and has done his PG DMLE from National Law School in 2019. Currently, he is a professor and head in KVG Medical College Hospital, Sulia, and he is also co-chair for psychiatry and law specialty in section in IPS. He is the past president of IPS KC during 2014 and 15, and past vice president IMA Karnataka State Branch in 2015 and 16. He is faculty of UNICEF IMA program in child sexual abuse prevention response team. And he is a recipient of IMA National Award Dr. Ramchandra and Murthy Award in 2016 and 17. And nextly, regarding Dr. Suresh Brahmat sir, Dr. Suresh Brahmat has done his MD and DNB from NIMANS, Bangalore, and he has additional degrees of PG DMLE and PG DHRL and PhD in law from National Law School, India, Bangalore. And currently he is professor and head of telemedicine center, head of forensic psychiatry services, and a consultant in community psychiatry. And he's a visiting faculty as well in National Law School, Bangalore, and State Human Rights Commission and Karnataka Judicial Academy in Bangalore. He has over 273 publications and in index journals, and also an editor of 3 books. He is a recipient of Professor Raghuram Distinguished Young Teacher Award and Dr. C.V. Raman Young Scientist Award from Government of Karnataka, and currently is member of committee instituted by Ministry of Health and Family Welfare, and he is also a member of Central Rule Drafting Committee for Mental Health Care Act 2017, and he is a member of Task Force of Mental Health Care in Primary Health Centers. Now I would like to invite both of the chairpersons to the session and introduce the speakers. Thank you.
Thank you, Dr. Gopal Das, for introducing. And we are on time, and I think this is the last session of the successful eKANCIPS 2020. And I also invite Dr. Anil Kakunje sir, Dr. Mohan Sunil Kumar sir, and Dr. Chaugle sir. I think all are there on the screen. And we have 3 speakers here, and each one will be given 30 minutes time. The first speaker will speak on addiction issues in women, recent trends. That is Dr. Mohan Sunil Kumar. And the next speaker, Dr. Anil Kakunje, will speak on internet and gaming disorder among children and adolescents, effects during COVID-19 pandemic. And the last speaker, Dr. Nikhil Chaugle, will be speaking on living with sobriety and preventing relapse, lesson learned from COVID-19 lockdown. So I welcome all the speakers. Before going for the presentation, I request Dr. Suresh Brahmat to introduce the first speaker.
Good afternoon, everyone. First speaker is Dr. Mohan Sunil Kumar. It's a great privilege to introduce Dr. Mohan Sunil Kumar. He did his DPM from NIMANS, but he completed his MBBS from JJM Davangere. Many people know less about him regarding he's the co-founder and a director of Augmenta Mental Health Private Limited. And also he's a chief psychiatrist coach, Center for New Beginning. Though he was my colleague in NIMANS, now I see many of his students because he teaches psychiatry in various academic institutions, and many of them undergo entrance exam training. So many of my students are new Sunil Kumar before they come to NIMANS. So Sunil has contributed immensely for the IPS, especially Karnataka, from the perspective of e-governance, or what we call it as e-health, or what we call it as digital health with regard to psychiatry. And he has been very active in our IPS, and also has been contributing with regard to publications, or it may be regarding various other conferences. He's been there supporting us since long. So without wasting time, I invite Dr. Sunil Kumar to do his presentation. All the best, Dr. Sunil. Dr. Sunil Kumar. Dr. Sunil Mohan Kumar.
I think there's a video I think they're going to play, I think.
Yep.
Addiction in women. This is the topic we are going to take up in this Kancips 2020. Before we go ahead with the topic, let me put up an important disclaimer. The characters used in this lecture are purely fictional. Any resemblance with people who are living or dead is purely coincidental. When this topic was asked, I realized I am supposed to deal with three complex things. What are the three complex things I'm supposed to deal with? One is the addiction, which is complex in its own nature. Behaviors have its own complexities, which we all understand. And of course, women have their own challenges and complex situations which they go through. When you're talking about addiction, you need to understand, for a contemporary psychiatrist, it's a kind of multi-headed creature which is creating trouble to us. So it is a hydra-headed problem for contemporary psychiatrists. We have newer and newer drugs, we have newer and newer methods of addiction, and we have newer challenges to deal with. For some, there are no solutions which we are able to find as of date. There is changing landscape of addiction, right? The way addiction has changed over years, the molecules which are used by people, young population, older population, the kind of methods and strategies used in addiction and drugs used, all of them have been changing over a period of time. So when you're talking about addiction, what do you basically mean? We are basically looking at a few important features, right? These are 6 important features we look for in a person to say whether they have addiction or not. 3 or more of these features being there can help us to understand that this person can be having a significant addiction problem. When you're talking about behavioral addiction, we are talking about some particular behaviors which can lead to trouble. Now, what you need to understand is these behaviors most of the times are normal behaviors which are very much accepted in the society. And these behaviors could be naturally rewarding and quite helpful, at least in the beginning times. It could give some gratification in the initial times. It could satisfy, or it could help, or it could make you feel better in some ways, at least in the initial times. These behaviors are what actually go on to become behavioral addictions in due course of time. Now, an interesting point to note here is when you're talking about behavioral addiction, gambling for that matter took about 3 decades of second-hand treatment to actually get included as an addiction problem. It is only in DSM-5 when it comes under the class of addictive disorders. Till then, it has been kind of been an outcast, even though a lot of studies over years have been showing that pathological gambling, which was the earlier name, or the gambling disorder, which is the current name, is a behavioral addiction. Now, there are some important behavioral addictions which have been quite well known. One of the important ones obviously is gambling disorder. Now, gaming disorder, even though in DSM-5 does not have a specific diagnostic place, it is in area of further research and study. Gaming disorder is included in ICD-11. Internet addiction, which is a very common term, a lot of people are talking about all over the world, you need to understand, still is yet to find place in diagnostic manuals. When you're talking about internet addiction, it is important for us to understand it's a complex condition. Now, people don't get addicted to the internet or the World Wide Web. They get addicted to internet and through it achieve many things. It could be gambling, it could be gaming, it could be pornography, it could be social media, it could be shopping, it could be wilfing. What do you think is wilfing? Wolfing is basically aimless searching over hours together. You just don't have particular agenda or an aim. You're just for hours together surfing something or the other on the net. That's wolfing, which is a common term used by people who are into excessive search. Now, news reading could itself become very addictive in people. Binge watching can happen, and with all the streaming videos and high quality videos which are accessible on the mobile phones these days, binge watching is increasing in numbers and are challenges of future. There are other types of behavioral addiction which can come in: exercise addiction, food addiction, tattooing, tanning, like that. If you see, there are different people talking about different kinds of addiction. As a mental health professional, we need to be a little careful and also ask ourselves, are we suffering from something like a nosologo mania? Basically trying to kind of term every behavior, every change as an illness and trying to put it into a criteria and trying to treat and diagnose. It is important for us to understand Griffith, who has done a lot of work in behavioral addiction, put across it in a very simple way. Excessive enthusiasm in any activity is normal if it is adding life, whereas if it is removing life or deleting life or reducing life, then it becomes an addiction. So talking about women in specific, you need to understand women have their own complex challenges which they go through, right? Male brain and female brain could be extremely different in its own way, anatomically, biologically, and those. And please understand the flood of hormones and chemicals which happens in a male brain and a female brain obviously is going to be different, because the biochemical architecture and the hormonal architecture of males and females are different, and they will have their own place to play. So even though we might not exactly know what chemicals, what area could play specific roles, that could be gender differences which we need to be remembering as a mental health professional. It also doesn't start only there, right? It starts right from the beginning. The first earliest question which is asked when a baby is born, at least in countries where sex determination does not happen, is it a boy or a girl? My interaction with the newborn is going to change based on the answer I receive. So we know addiction problem is a biopsychosocial problem like many other mental illnesses. So if you assume that it's a biopsychosocial problem, you need to understand the biopsychosocial differences in men and women are going to be so much different, and it is going to influence everything right from the initiation of addictive behaviors, maintenance of addictive behaviors, the course of addictive behaviors, the way they take treatment or the outcomes of the treatment. All of them are going to be involved or influenced by the biopsychosocial model. Addiction in the context of gender has to be looked upon very differently, and what works in men might not work in women, what works in women might not work in men. So understanding these complexities and interplay of various factors could help us to exclusively design treatment plans for those individuals who come in distress and meet us. Now, why are we talking about genders and differences? It is also important for us to understand some things are becoming more equal, right? There is a reducing gender gap in the substance use disorders. We all know world over, males smoking is reducing, whereas women's smoking is increasing and the gender gap is coming in. Let me ask you this simple question to think over. Males and females, I did mention about a list of addictions, right? So what do you think could be an addiction which could be potentially more common in male? I'm sure the first thing which comes to your mind potentially is sex addiction, right? So sex addiction is about 4 times more common in males. There are a few addictions which have been studied to be more common in women, like for example, shopping addiction and eating addiction. So it's important for us to realize these are some conclusions in some studies which have come in, which shows some particular behavioral addictions could be more common in men and some more common in women. Now, since we're talking specifically about women, I would like to highlight a few points. In a lot of studies, substance use studies as well as behavioral studies, it is very well known that one of the bad prognostic factors, or one of the factors which influences chances of relapse and chances of poor recovery is a history of trauma and abuse. Now, you do know that in this society, for whatsoever be the reason, women have unfortunately a significant negative share of trauma and abuse potential which can happen to them. So it can make them have more vulnerabilities to the whole substance use as well as behavioral addiction problems which can happen. Not just that, a lot of studies in women have spoken about something called as telescoping. Women typically, whether it is substance use or even behavioral addiction, even if they start little late in age, they kind of fasten their process of worsening and kind of reach the dependence patterns or addictive patterns much earlier than men. So that is what is called as telescoping, where the start and the worsening is much shorter in women compared to men. When you're talking exclusively of relapse, you need to understand a lot of factors can play a role in relapse, but some important factors which makes women more vulnerable to relapses are affective symptoms or mood symptoms can be a trigger for relapse in many people, right? Whether it is substance or behavioral addiction. So affective symptoms being more common in women increases the chances of their relapse. History of abuse, which I did tell, or trauma, which I mentioned, is one of the important factors for relapse, and again making women more vulnerable to it. Studies have shown there is an increased sensitivity to stress, trauma, or even addictive substance cues or behavioral cues. So the increased sensitivity to the trauma, stress, sensitivity to the cues of addictive behaviors or substances, all of them make them more vulnerable for relapses compared to men. So that's another important point we need to remember. So what else makes women more vulnerable to a relapse? Obviously, there can be stigma issues and support issues. Dual diagnosis and comorbidities are more of a rule in women compared to men. You do see dual diagnosis and comorbidities in men too, but you need to understand when you're talking about the addictive population in women, it is much more. Now, you need to also ask yourself, is it the cause or is it the effect of addiction? When you're talking about addiction, you need to understand why addiction happens, right? Like, for example, let me keep it very simple. We need to talk about 3 Ds. One of the important Ds you need to remember is dynorphin. Now, dynorphin is a chemical which is released and it numbs the nucleus accumbens area. When it numbs the nucleus accumbens area, you need more of the stimuli, more of the substance to get the same high. So this dynorphin numbing the nucleus accumbens is one of the reasons you end up developing tolerance to the substance or a behavior. So that is one explanation for addiction. Another explanation for addiction is the dopamine, which plays a role in giving the high or a kick. But please remember, it's not just the high or the kick which is important here. It's the incentive salience which is the crucial factor. What is the incentive salience? Incentive salience basically means it's the extreme importance or extreme positive feeling or binding which is given to that experience when that substance or that behavior is done. That incentive salience is a crucial factor, and dopamine is the chemical behind it. The other D which you need to remember is disinhibition process, which happens a little later stage of addiction, where you typically see prefrontal area circuits changing a little bit and their control on the rest of the brain kind of eases out, which basically means the person's decision making abilities comes down, judgment processes come down, and they get into the spiral of addiction. So these are 3 crucial Ds for any addictive behavior which can lead to addiction, right? One of the important points in behavioral addiction, especially you need to look at, is supernormal stimuli. In a lot of behavioral addiction, you're looking for not just a normal stimuli, you're looking for a supernormal stimuli. Any gaming today is supernormal stimuli. Any junk food is full of energy, full of calories. So it's supernormal stimuli. So immersion factor. This immersion factor is especially important in audiovisual material, like for example, gaming or even binge watching, right? You could see a lot of this content in gaming or any of the movies and series which we watch has so much of immersion factor that the person who's watching it gets immersed into it so much, and he gets grappled with the content so much that he finds it very difficult to get off that. That is called as the immersion factor, and that is an important way of explaining behavioral addiction. Another interesting point you need to remember is in behavioral addiction, you get to see this partial reinforcement effect. What is this partial reinforcement effect? Suddenly, some extraordinary luck favors you and you win a jackpot, or suddenly you win a huge prize money, or suddenly one of the episodes is very interesting. So this unpredictable wins and unpredictable gains which you get makes your brain look for that and chase this high multiple times. So you need to understand these are some of the important explanations for how behavioral addiction can happen. Another way of explaining and understanding behavioral addictions in any gender, especially in women, could be the ABC model. And I did talk about affect being an important factor which we need to look for in addiction of substance as well as behaviors, right? What is this ABC model talking about? A stands for affect, B stands for a behavior, C stands for cognitions and control related issues. So whenever you're talking about a behavioral addiction, you're looking at some changes in the mood and a behavior which changes that particular mood. So once the behavior changes the mood, it changes the way you think, and sometimes maladaptive cognitive processes can get kicked in and discontrol can happen. So behavioral addiction can be explained by this ABC model. There is another way of explaining behavioral addiction, which is like something called as components model for behavioral addiction. What is this components model of behavioral addiction? It does look like substance use disorder only, where they look for salience, mood modification, tolerance, withdrawal symptoms, conflict with themselves and people around them. So they start prioritizing that particular behavior to such an extent that they get into conflict with other situations. An interesting point for us to look at is to see how behavioral addiction can evolve or start off. A pathway to trouble, which I call it as. Now, when you're looking at pathway to trouble, people can have their own vulnerabilities sometimes. There are a bunch of people who have vulnerabilities and go on to develop addictive behaviors. In some of them, they can have personality traits. They are high risk taking people. They have already been on the edge, getting into various kind of challenges, and one fine day, they get into bigger problems. So they carry traits, and the traits one fine day led into addictive behaviors. There are, of course, some people who out of the blue get into addictive behaviors. So if you look into the pathway into trouble, there are people who might have some vulnerabilities in terms of genetics or mental illnesses. There could be people who have some traits of personalities and those which makes them vulnerable and due course develop behavioral addiction. And in some people, it can be out of the blue, very difficult to explain. Idiosyncratic processes can happen as a pathway to trouble. It is interesting to know that behavioral addiction is not as simple as what we are talking about. So let me highlight a few important points here. If you're just talking about gaming and gaming addiction, it's just not about they like to play. You need to understand there are different types of gamers. One are those explorers. The other one are those achievers. The third one is socializers, and fourth one is killers. Explorers are the people who want to just play game to understand how it happens, what next level, and they just want to explore. Achievers are those people who want to reach the top. They want to go to the next level. They want to finish the thing and keep achieving for themselves. Socializers are those people who through the game like to connect with others, through the game like to kind of play with others, and those. The killers are those people who just don't want to achieve. They want to go ahead and beat everybody, become the best, and they want to kind of ensure that others' plans are ruined, and they go up and they want to sometimes take revenge in that game. If they lose one, they don't want to give up till they win you back, and those kind of ideas. So that's what is the killers. So these are different types of gamers. So what am I trying to highlight here? If you have seen a few slides, I've shown chemical changes which can happen. I've spoken about behaviors and how complex it can happen. I'm also trying to say each behavior and each addiction can be pursued by different people for different reasons, and that is what we need to figure out when we are thinking of behavioral addiction in people. One interesting point to summarize how complex behavioral addictions could be is, let's talk about a point of payment, okay? Paying money. There are addictions where you spend money, like shopping addiction is where you spend money and you kind of try to feel a kick out of it or a thrill out of it. Kleptomania is kind of considered by some people as a behavioral addiction, impulse control kind of a disorder, where they steal and get a thrill out of it. If you look at gambling, they get a high or a thrill by winning. So if you see money stealing, money winning, money spending, so all of it can lead to behavioral addictions of different levels and different nature. So what does that mean to you? It means that behaviors are so complex that each one pursues their own agenda and goal. And as a clinician, our job is to figure out the person who's sitting in front of us, what is their challenge, how are they connecting and perceiving in their brain, and helping them in that process. That's what would help us in these behavioral addictions. Why should we be worried so much about behavioral addictions? Of course, we know substance use disorders cause a lot of health issues and those, so we need to be worried about it. Does behavioral addiction lead to same issues? Yes, it leads to multifold impact, and the impact can be similar to substance use disorders or even more sometimes, because people end up coming with behavioral addiction problems much later compared to what substance use disorder people can come in. We would be wanting to help, but help seeking is one of the biggest challenges in behavioral addiction, mainly because a lot of times people kind of don't accept or don't understand that they might be having a behavioral addiction till it's too long into the process. So help seeking is quite a challenge. It is not just that. You need to understand a lot of times there is a lot of therapeutic nihilism. So if you try to help these people, like in substance use, right, it is important for us to ask ourselves in behavioral addiction also, what are you looking at? Are you looking at abstinence or are you looking at non-abstinence? Now, why is this important, especially in behavioral addiction? Some behaviors you cannot get into abstinence. For example, you can't ask people not to use internet at all, because internet is part and parcel of life for many and they cannot get away from internet usage. So you need to understand, in them you have to have a non-abstinence goal. And you also need to realize having abstinence always would be very difficult, because a lot of people might not be looking for it and they might be turned down to take help. The core points to look for helping these individuals are awareness and engagement, treatment and follow-up. First of all, there should be awareness, understanding, assessment, and those. You need to get them to engage, of course, treat them adequately and have adequate follow-up. If all these things are done, is when we should be able to help these individuals over a period of time. Medications that work in behavioral addiction especially, first of all, you need to understand, if you're asking for medications that work, there is no exact medications that work. Moreover, there are a lot of medications which are tried, is what you need to understand. Let me put up a list here for you to understand that these are some of the very common medications which have been tried: naltrexone, N-acetylcysteine, topiramate, bupropion, fluoxetine, others like some antipsychotics, mood stabilizers, other antidepressants, What you need to understand here is, if you can identify comorbidities, if you can identify other mental illnesses, it has to be treated, because that many times is an important maintenance factor. So it's good idea for you to look at medications to treat the comorbid conditions for sure. Of course, in addiction, we know medicines have its own role to play. In substance use disorders, more established studies are there, whereas in behavioral addiction, you do have some reports here and there to talk about level 2 alternatives and see what might be suiting the individuals, and think of some of these drugs in treating these patients with behavioral addiction. So what are the other strategies how you manage behavioral addictions? One is look at behavioral modification, look at cognitive restructuring, and look at harm reduction. These are three important things you need to look at. It is important to look for common cognitive distortions like superstitious beliefs, attributional beliefs, gambler's fallacy. There's a very common problem in gambling disorder. Chasing can happen. You know of chasing in substance use disorders. Like that, here also chasing a high is very common in these people. Anthropomorphism is basically trying to attribute it to their failures and success to particular machines and those. They believe, okay, today I lost big money because I played on this slot machine and not on this slot machine. Today I lost a lot of money because I used this laptop rather than that laptop. So like that, they kind of think that their failures is not because of some flaws in them, but because of some inanimate objects and those. Like that, they can have illusionary sense of control and association, which all makes people to get imbibed in this whole behavioral addictive processes, which you need to work over period of multiple cognitive behavioral sessions. Strengthening their cognitive control is extremely important. How do you try to strengthen the cognitive control? Identify patterns, manage high risk zones or slip zones, and get them to do alternative healthy habits. That's the key for getting anybody out of behavioral addiction. Identifying patterns, reduce the slips, and most importantly, alternative healthy habits. Can you do something in terms of prevention? Answer is definitely you can work towards young population, especially in some behavioral addictions which are part and parcel of life. For example, social media is part and parcel of life, internet is part and parcel of life, gaming could be part and parcel of life. So like that, financial transactions and those could be part and parcel of life. So if you want to avoid people getting into addictive behaviors, you can make people talk about it. You can make people talk about it, their experiences and those. More importantly, you can get children involved in together activity. Means you make them play along with you, you play along with them, teach them what's okay, teach them what is moderation and those things. Like that, when you get along with them, talk about it and together activity or together play along with them, the chances of them opening up and taking help in the initial stages becomes much more higher. Also important is to get them to allot and stick to it. For example, kids right from the beginning, if they're asked to allot by themselves how much time they want to play and make them stick to it and reinforce that kind of behaviors, it helps them because over a period of time they learn to regulate themselves rather than actually needing external resources to be regulated. Also, learning to have alternative activities. Like for example, even if kids like to play online, let's imagine they like to play online cricket. It's good, okay, let them do that. But they also need to do other activities which are alternative healthy activities. Maybe play real-time game outside with their friends. Also, they can do some online games. Like that, if they have alternative activities also happening in parallel, the chances of preventing behavioral addiction becomes higher. So talking about it, together activities, allot and stick formula, and of course alternative activity encouragements. These are strategies by which you can do some prevention. The moment you diagnose a behavioral addiction of whatever it is, shopping addiction, gambling addiction, anything like that, it can have its own legal implications and those. So there are a lot of cases, at least in countries like US and those, where people who are into gambling addiction have gone back and they have not been able to pay their loans back and have claimed because they are sick they will not be able to pay and they have got into trouble. Like that, you need to understand these are all future challenges which can come to mental health professionals, where custody of child can be questioned because of behavioral addictions. These are challenges which we need to be looking forward in future and addressing it in more healthier manners. Before we wind up, one important point I would like to highlight is we are a stereotypical world. Whether we like it or not, most of us find it very difficult to change the thought processes of our thinking. There could be a sheer fundamental attribution error which could be behind many gender problems we see. What is fundamental attribution error? You attribute the problems or a failure to the person rather than other external factors sometimes. That could happen many times in female gender, and we have had many examples where fundamental attribution error is an issue. So why am I highlighting this point is because as a clinician, a lot of studies could be biased because of gender selection and those. So it's important for us to realize with the limited data we have, behavioral addiction is something we cannot run away from. It is going to be there and it is going to increase over a period of time with all the technology interface and other things which have come in. So we need to learn how to deal with it, how to manage it together, and maybe like Kancips 2020, in Kancips 2025, maybe we have better evidences, better treatments, better strategies to help these people with behavioral addiction in all genders, but of course, behavioral addiction in women. I hope we should be able to help them in the best ways possible. Thank you.
Thank you, sir. Thank you, Dr. Mohan Sunil. Behavior in women. Now we take the questions, but the questions will be taken at the end of the session as mentioned in the brochure. Now we'll go to the next speaker, Dr. Anil Kakunje sir. It is my privilege to introduce Dr. Anil Kakunje sir. He is the professor and head of the department from Yenapaya Medical College. He is an alumni of Sri Siddhartha Medical College, Tumkur, and got his DPM from National Institute of Mental Health and Neurosciences, Bangalore. And then later on, he did his MD from KMC, Manipal. Presently, he is working as a professor of psychiatry at Yenapaya. He has edited 3 books and published 55 articles. And presently is the editor of Indian Psychiatric Society Karnataka chapter. And he is also field editor of Indian Journal of Psychiatry. And he has received many awards. Best Outgoing Student Gold Medal in Psychiatry Award for the year 2008 from Manipal University. Received the Young Psychiatrist Tract Award by World Association of Social Psychiatry, and received prestigious Professor Raghuram Distinguished Young Teacher Award from IPS Karnataka chapter. He is a tiger because he is representing Karauli Tigers in cricket. I also would like to add, we have Lion sitting with me, Dr. Badamat, who is representing Bangalore Lions in cricket. So it is very nice to hear Dr. Anil Kakunje. Kindly go ahead with your presentation on internet addiction on children and adolescents, the background of pandemic 19. Thank you. Kindly go ahead.
Hello everyone. It's a pleasure to speak on an e-topic for eKANCIPS. The title of my presentation is Internet and Gaming Disorder Among Children and Adolescents, Effects of COVID-19 Pandemic. I'll start with a quote. Only on the internet can a person be lonely and popular at the same time. Alison Burnett. Think over it. Coming to the introduction. Large-scale studies suggest that internet and gaming disorders among children and adolescents has become an important public health concern. Since the publication of DSM-5, large-scale studies and research on the topic related to internet and gaming disorders have increased dramatically and drastically. Children are at increased risk of harm online during the COVID-19 pandemic. This was a recent UNICEF warning. All of you will be familiar with Maslow's pyramid. That was probably Maslow 1.0. If you have a Maslow 2.0 related to the digital needs, it will be something related to weapons of mass distraction. At the base of the pyramid, you would see the physiological needs. You need an internet, you need a mobile phone, you need a computer, you need Wi-Fi, you need battery, and so on. Then you have the security needs. You have the passwords, you have your mail IDs, you have the fingerprints, and so on. Your Google IDs, Gmail IDs, all these are security needs. Then comes belonging and love needs. Your Facebook accounts, your Tinder accounts, your WhatsApp accounts, your Instagram accounts, all those are belonging and love needs. Then higher up, you have your self-esteem needs. Those are your Twitter accounts, Instagram accounts, and so on. And at the height of the pyramid, you have the self-actualization, probably your LinkedIn accounts and your YouTube accounts and your live streaming accounts, say uploading videos and so on. So probably this will be something like a Maslow's 2.0 digital needs pyramid. If you ask me what has happened after the COVID-19 pandemic related to the digital field, I would actually have to tell what was there earlier and what changed, something like before and after. So here we can see our organizing secretary before lockdown and after lockdown. Most of us have gained weight, he has become more fit. Coming to children and schooling, so you would notice schools have become totally digital. So children are not in the classroom, they are at home and meet their friends online. Coming to internet addiction per se. So it was sometime way back in 2008 that American Journal of Psychiatry wrote an editorial on internet addiction published, written by Gerald Block. He had written in 2008 that internet addiction appears to be very common and it needs to be included DSM-5. It is still not included, but then something related to internet and say gaming disorders has been put in the appendix. He said conceptually diagnosis, it is more related to the compulsive and impulsive spectrum, and it is more related to texting, use of digital space, sexual preoccupation in the digital space, excessive gaming and so on. And all these internet disorders are almost similar to substance use disorders, and they have excessive use, development of tolerance, there is withdrawal, and people develop psychological and physical problems related to it. So by and large, there are a lot of similarities between the behavioral addictions and substance addictions. Internet addiction and gaming disorders. Internet addiction disorder is also known as problematic internet use or pathological internet use. DSM-5 summarizes internet gaming disorder as persistent and recurrent use of internet to engage in games, often with other players, leading to clinically significant impairment or distress. So there should be all are using, but then there should be clinically significant impairment or distress. Both are not a DSM or an ICD diagnosis currently, but then gaming disorder is in the appendix and needs more research according to DSM, and ICD-11 mostly may have this as a diagnosis. So we need to improve upon, improve our research on this area. World Journal of Psychiatry wrote a commentary on internet addiction and the problematic internet use that mentioned that in the last 15 years there has been a 1,000-fold increase in internet use, and with frequent internet use there has been psychological and physical problems, and research on this area has increased, and we need to be more and more aware of the problems related to the internet. European Pediatric Association published a commentary and a position statement on internet addiction related to children. So it mentions that children's well-being should be taken care of in this digital world, and their emotional and psychological needs can be very much affected with the growing digital space and digital arena. So it says that children's well-being needs to be taken care right from early childhood. It goes on to say that in Europe, people have a mobile phone by around the age of 9 years. So 9 years is roughly around, say, second or third standard in India. So people have a mobile phone at that age and they use internet much before. This was published, say, about a decade back. So if you see the current world, people use mobile phone much earlier, and even before schooling, people know to browse internet. So that is where we stand, and we need to be very much careful related to, say, the exposure of the digital world in very young children. What does APA guidelines say? The APA guideline says avoid all devices, the digital devices, before the age of 3 years according to the APA recommendations. But the WHO recommendation says there should not be any digital exposure or say digital involvement of children before the age of 2 years. So before 2 to 3 years, there shouldn't be say internet, too much of internet penetrations in a child's life. But what do you see? The lullaby for a very young kid is given by the mobiles, and in the recent lockdown, all the family members are locked in their own phones. So that is where we stand in the current world. And children and internet become too close and too involved to be separated. So coming to what has happened during the lockdown. So all of you would agree, and the data also shows internet use has surged during lockdown. There have been so many reports. The telephone companies, Jio, Airtel, all are doing well. And there are several reports saying coronavirus lockdown, internet consumption has jumped more than 30%, 40%, and so on. And I am reaching you also through the internet, and everyone's internet is consumed. So that is where we stand. So what is the gravity of the problem? A study which was conducted online across 30 Indian cities concluded that children's addiction to electronic devices during the lockdown increased up to 3 times, as they spent between 2 to 5 hours every day on their favorite gadgets. It may be for schooling purpose or otherwise, but then internet use has increased. So what has changed after Corona? Work, news, leisure, friendship, family, play, everything is online. So very much inseparable probably. So internet addiction in children. So according to UNICEF, about 1/3 of internet users are adolescents, and they are at increased risk of internet addiction during the pandemic, as their lives have become totally online. Unstructured use of internet can make their life more and more vulnerable to internet addictions, gaming addictions, sexual exploitation, bullying, breach of privacy, financial frauds, and so on, which can happen easily over online activities. So why children are at increased risk? The cognitive development is still happening in children, and it may be difficult for them to perceive everything as it is. Their cognitive control is very immature, so they may go only with the pleasure drive, so it would be difficult for them to have a control. And not all children are aware of the risks involved in online platforms, especially the younger ones, so they may be easily be bullied, they may be at risk for several problems. And they don't have required skills and knowledge to safeguard themselves. So what to reveal, what should not be revealed, usage of passwords, usage of privacy, all those things need to be taken care of. And because of their daily classrooms and increased usage of internet, so increased computer knowledge, they may try to experiment on various things over the mobile or the digital space, which can lead to problems. This is a very interesting study on, psychological factors related to well-being in children and adolescents coming from China following the pandemic. So these authors looked at children between 16 to 18 years old, both boys and girls. They looked at the Young's internet addiction scale, as well as the DAS scale, the depression, anxiety, stress scale. The total sample size was quite big, about 2,050 participants participated. The average mean size of the participants was about 12 years. And what they found out was about 2.5% of the young kids or children were addicted or having internet addiction, and about 1/3 of the total participants of the total 2,050 odd participants were classified to have problematic internet usage. And they say that internet usage has grown during COVID-19 pandemic, and the stress and the depression, anxiety is related to increased internet addiction. So this one large study, agreeing on, confirming the psychological effects of growing internet usage. So what about social media? So you have an internet addiction, you have gaming addictions, you have gambling and so on. So is there something called as social media disorder? A lot of people are writing on this. So increasing research is advocating that there should be something called a social media disorder, where people talk about WhatsApp addiction, Facebook addiction, and individual addictions, Instagram addictions, and so on. So each individual social media can be a separate individual can have individual addiction. So people broadly call it, started calling it as social media disorder. So all these internet addictions, are they addictive behavior or is it a coping mechanism? So the authors of this article are from India. It is published in the Asian Journal of Psychiatry, which is yet to come in print. It is 2020 December publication. It's come online. So they discuss whether increased usage of internet has become an addiction, or is it a coping mechanism of, since you are isolated at home, you face loneliness, you have a lot of anxiety, people can have a lot of psychological problems, and the way to cope and be in touch is via the internet, and increased usage is whether it's a coping mechanism. So they argue for and against this. It's a quite a brief, interesting article. Another problem which has come up following the internet is the pornography usage during the lockdown. I think many would have noticed this newspaper reports which has come during March-April period, the heights of lockdown, that pornography gets pandemic boost. India reports about 95% or a doubling of pornography usage during lockdown. So what can happen is children are at home and some people forget to delete the internet history, or sometimes you get pop-ups while viewing the mobiles or the laptops via surfing. So children can accidentally view or get exposed to pornographic material, which can lead to problems. It has actually been reported by several psychiatrists and been published in media also. It's a Times of India article that lockdown children are exploring more porn nowadays because of increased mobile and internet usage and increased surfing in the internet following their online classes. So what problems are reported following increased usage? There are emotional problems, mood changes, anger, problems with concentration, impulsiveness, irritability has been reported, depression, anxiety, social withdrawal, cognitive problems, concentration problems, academic decline, peer problems, somatic complaints, loneliness, headache, sleep disturbance are few psychological problems to report, tell. Physical complaints are also reported in children like eye strain, back pain, neck pain, sleep problems, and so on. Coming to gaming addiction. So gaming addiction is in the appendix of DSM. The incidence of internet gaming addiction is about, say, 1 to 5% in teenagers, all teenagers. It is more in boys compared to girls. About 1/3 of users of gaming addiction are less than 18 years. And if you see the reporting of internet gaming addiction, a self-reported study showed that children report about 1.3% of the people have internet gaming addiction. But if you ask their parents, it is about 2.4%, almost double. So that means children report less. On an average, child spends about 4 to 6 hours on gaming, and it's roughly about 1/3 of their awake time. And low to moderate problems are sometimes called as, say, there is a problematic gamer group, which is now, the terminology is now popular. They all may not be addicted, but then there could be problematic gamer group. So which games children are more using? The common ones are the shooting action games. All of you will agree that children are fascinated with the guns, and those are the most popular ones. One of the studies said almost 96% of the children who use games prefer shooting games. And the next common one is multiplayer online games. It is not the individual games, so you have multiple people joining from all corners. So those are the more popular ones. Which are the problematic games? The first person shooters, no prize for guessing that. And the next problematic one is the massive multiplayer online role-playing games. So these are games which come with themes. So the few ones to name is the Pirates, and you have the Star Wars. They come with a theme. So you have increasing levels of the game. So you can customize it. You can interact during the games, and you can chat with the other players. So these are very popular, and they can create, they're very addictive and can create more troubles. And the very popular one, which was recently banned by the government in India, is the PUBG. So PUBG is the short form for Player Unknown Battlegrounds. So many of you who have some experience with PUBG or would have definitely heard of PUBG. There is a PUBG addiction scale. People have talked about PUBG addictions. So it is very dramatic, the whole game, where people come in aeroplanes, land and shoot people. You get points, you get weapons. So it increases your adrenaline. So some time back I had a patient a lady, daughter-in-law, who had problem with her mother-in-law, and the whole frustration, she said that she would ventilate by playing PUBG the whole night, and she would enjoy shooting the opponents and players, and that would give relief to her frustration and stress. The other one is how do you compare between online and offline games? One study compared online and offline gamers and indicated that online gamers were more likely to score higher on overuse, interpersonal conflicts, social isolation subscales of problematic online gaming questionnaire. So no prize for guessing that. Online definitely is say more addictive, and it is more interactive. So you enjoy playing online rather than offline. Coming to gaming and academics, so it definitely affects academics. Muller et al. Reported that secondary school students with gaming addiction had lower academic performance compared to their non-problematic gamers or non-gamers. If you compare with other fellows, other classmates who are not addictive, so they report they score lower in their academics. Rabin et al. Observed that internet gaming addiction was reported to interfere with daily living, including schoolwork, and there have been missed absenteeism, more absenteeism in people who have gaming addictions. They compared about 6 months attendance, and they said that in the 6 months, people who were addicted to games were absent about 19 days compared to non-gamers for about 4 to 5 days. Coming to various scales which are used in internet and gaming addictions, you have the internet addiction scales for child, digital addiction scale for children, and internet addiction test. And for gamers, for gaming, you have gaming addiction scale, game addiction scale assessments, and the scale for assessment of internet and computer game addiction. Coming to how do you manage the kids with all these problems? So simple ones are having an activity scheduling, not to disturb their eating habits, sleeping time, and personal hygiene time. So all these things should not be disturbed with the internet or say using mobile phones. Have regular exercise, have socializing activity, physical socializing activity with other family members, other kids, or increase the offline activities for children. So you can have family time, do other activities other than online games and being on the internet. Have scheduled family meetings, family time, especially dinner time, where people can share and join together, and people shouldn't be online during that time. For a little older ones, you can have self-monitoring of your internet activities, have a limited screen time. You get parental controls now, so apps and phones can have some parental control so that children don't browse few sites or don't go into few apps, those can be done. There are something called as well-being apps, or there are even digital well-being apps where it says that how long you have been online, what were your activities, what sites you saw for how long, and so on. So that can give a good feedback on your activity at the end of the day. And it's definitely a good idea for parents to join child's online game and know what games they play and what is in it, and it is kind of bonding also. Coming to other management plans, pharmacotherapy has a limited role. SSRIs have been tried, escitalopram has been tried, bupropion has been tried. There are 1 or 2 small trials on naltrexone, but then it is not very robust. Fluoxetine probably could be tried in children. But then the key is multimodal approach in management of internet addiction. There has been a great talk about digital detox. It is a way to disconnect and reconnect. So you can take a break from your digital world. You should have a healthy digital diet, a healthy nutrition related to the digital world. And it is always nice to start small and build up slowly, gradually, so that you slowly reduce your usage of, say, apps and digital activities. People are talking about digital detox retreat, where people go and stay on a holiday and without using online gadgets, and staying offline, being with the family. So people go for even paid retreats, digital detox retreats. So that's a big business now. And it's always good to regularly unplug yourself from the mobile phones. Lastly, few slides on our experience. It would not be complete just reading someone else's experience. So we have done few studies related to this field in our department. Facebook addiction and loneliness in postgraduates, students of university in southern India. We looked at about 100 postgraduates, looked at their Facebook addiction scale and their California, Los Angeles loneliness scale. And the results were that about 1/4 of the students reported Facebook addiction, about 1/3 had problematic internet usage, and it was significantly correlated with loneliness. So people who have a lot of Facebook usage may not be always happy and more lonely sometimes. Another study from our department related to smartphone usage, we looked at about 350 undergraduate students and their smartphone usage, and again no prizes for guessing. All the 325 students had the smartphones, and about around half of the students reported about 4 to 6 hours usage on of smartphones, and majority were about 1/3 among the females, and about half of male students had addiction to smartphones. So again, undergraduates, smartphone addiction is becoming more problematic. Another study is on internet addiction and sleep quality. It looked at the internet addiction scale with Pittsburgh Sleep Quality Index, and about the participants were about 150 undergraduate students, and the results was that people who had more internet addiction had problems with sleep. So, and internet addictions were seen in about 35% who had moderate addiction, and about 1/4 had mild addiction. So the gist is people can have problems with sleep when they are addicted to internet. So internet has entered our life right from birth to the funeral. Even funeral services now have gone digital. So that is where we stand, and even condolences are offered digitally. In the end, to summarize, COVID pandemic with more online activities has increased digital addictions. We should have, there is a biopsychosocial model. The whole internet addiction is on a biopsychosocial model, like many of the psychiatric illness. It negatively affects the child academically and psychologically. Prevention and early identification is the key in the treatment, and we should have a multimodal approach at various levels in management of children. So thank you.
Thank you, Dr. Anil. It was a wonderful presentation, and you are able to conceptualize the whole internet addiction, the way the children and the way the current situation is going on, and also talked about how we have to, as a parents or maybe the policymakers or working with the society, how we have to educate our public regarding the internet addiction. Now, moving to the next presentation by Dr. Nikhil Chaugle. He's working in a Swastik hospital. He did his MBBS from Russia 2003, and he completed his MD psychiatry from DY Patil Medical College, Navi Mumbai, and he's an associate professor at the Department of Psychiatry at DY Medical College, Kolhapur. Next to Dr. Nikhil Chaugle.
The organizing committee of eKANCIPS 2020 for giving me this opportunity. So my topic is living with sobriety and preventing relapse, a lesson learned from COVID-19 lockdown. As you all know, COVID-19 has brought a unique and unprecedented situation in terms of chronic social isolation, physical distancing, and sustained lockdown access across many countries are resulting in various undesirable outcomes with respect to health and well-being. A big chunk of world population has been encountering newly developed concomitant psychosocial stressors such as prolonged home confinement, depression, and panic due to unknown nature of the disease, fear of contracting infection, vulnerability to work from home, anxiety regarding flow of income, job loss, etc. And on top of that, abrupt unemployment is causing extreme difficulties for people of low socioeconomic group. And along with this, it has affected mental health to a great extent, leading to numerous psychological disorders. And one of the psychological disorder which we need to consider is substance use disorder, because substance use disorder is one of the major affected group during this pandemic. Now, amongst substance use disorders, as you all know, substance use disorder is characterized by an array of mental, physical, behavioral symptoms, a great public health concern claimed directly or indirectly the lives of millions of people every year. The alcohol consumption and illicit drug addiction cost around 1.5% of the global burden of the disease, and it can be as high as 5% in some nations, according to recent data. 2018 report by WHO noted that about 2.6 lakh deaths in India occur each year that directly or indirectly traced due to excessive alcohol consumption. The national average of almost 30%, according to the National Family Health Survey conducted in 2015-16. When the nationwide lockdown was introduced, it has affected substance use disorder in two ways. First, those people with substance use disorder who were dependent to substance, after the abrupt cessation or sudden unavailability of the alcohol or the substance, they presented with a lot of withdrawal symptoms. That was the initial presentation of most of the patients with substance use disorder. There was one study conducted in Kerala. They noted that they had received numerous calls regarding the substance use, and there was the main concern was withdrawal symptoms. Now, even in the recent recent paper which was published by Psychiatric News, the study conducted by Pollard and his colleagues, about 1,500 adults from the age group of 30 to 80 were included in the study. The study was even a retrospective study was done, wherein they had evaluated the consumption of alcohol during the period of April to June in 2019, and during they have taken the same period, in 2020. We have seen as high as 14% increase of alcohol consumption during the pandemic, during this pandemic. Now we need to see that there were some countries where alcohol was not banned, particularly European and Western countries. There we have seen the surge of or increase the use of alcohol or increase consumption of alcohol, as alcohol had come under essential commodities in some in these countries. Whereas in India, as there was ban of alcohol or strict ban of alcohol during the entire period of the lockdown, we have a different scenario. Now, addiction is conceptualized as a chronic relapsing brain disorder. Miller and Hester reviewed more than 500 alcoholism outcome studies and reported that more than 75% subjects relapsed within 1 year of treatment. A study published by Hunt and colleagues demonstrated that nicotine, heroin, and alcohol produced highly similar rates of relapse over 1 year period in the range of 80 to 95. A significant portion of patients receiving treatment for alcohol use disorder have at least one drink lapse within a year of after treatment, whereas about 20% patients return to pre-treatment levels of alcohol use. So we need to understand that alcohol use disorder, alcohol addiction has high chances of relapse. And whenever this kind of an unprecedented situation wherein a lot of psychosocial issues have come together, definitely that had increased the chances of relapse. Now, just because an individual manages to stop abusing alcohol or drug does not necessarily mean that his problems have gone or it has left behind. In the reality, it is that the stopping substance abuse is just the first step in a long process that leads to full recovery from addiction. Those who remain abstinent from alcohol or drug without achieving sobriety will struggle to find any real enjoyment in their life. And these are the people, or this is the vulnerable population which are at risk for the relapse and which we need to take care of. How quarantine, COVID-19 situation or the lockdown has affected people with substance use disorder. Now, people with an addiction who aren't yet sober, they are at higher risk now. Individuals who are sober and trying to remain sober, this is one population. People with dual diagnosis and other comorbidities are at higher risk. Family members of those with an addictions. So this is a population which is vulnerable for relapse. Now we have seen many people relapsing during this pandemic or during this lockdown period, and there are multiple stages of relapse which we need to understand, and there is a mental relapse before the actual relapse, and that we need to see that how it develops or how relapse occurs. So the stages of relapse I will elaborate in the latter part of my presentation. But before going to that, I would like to give one example from my clinic. Here's Mr. ABC, a 32-year-old male, an engineer by profession, residing in a city in a recently purchased apartment on finance along with his family. He suddenly lost his job during COVID-19 lockdown. About a year ago, he was diagnosed with alcohol dependence syndrome, took treatment for the same, and was abstinent from alcohol for nearly 6 months until 2 months back. During interview, he mentions that I have nothing to do or look forward to. I hate this COVID because it has ruined everything in my life. I lost my job, I can't see my friends, I can't go anywhere. So I drink and I get high. And it passes my time. I also crave every day. There is a history of high risk taking behaviors to seek alcohol and problem with legal systems as well. He says nobody cares and get bored sitting at home all the day and don't have interest in doing anything. The constant fights with wife and other family members. He often has withdrawal symptoms whenever he would not get any alcohol. He tried seeking help from alcohol, from doctor, but couldn't able to see him because of the lockdown or unavailability of doctors. Now, we need to understand the symptoms which were exhibited by this Mr. ABC. Now, the first and foremost symptom was because of loss of his job, he was, and lockdown, he was housebound. Because of housebound, he had loneliness, boredom, then craving for alcohol. Then when he realized that he has other financial stresses and other stresses, because of the same, he continued the use of alcohol. He also had risk-taking behaviors. We had seen some mild depressive features as well in the form of loss of interest, activities of doing things. Along with that, withdrawal symptoms, failed to attempt to stop using alcohol. So we need to understand or evaluate the psychosocial aspect of the relapse, and at the same time the symptom which they exhibit or contribute towards their relapse, because these are the factors which are going to help us in managing relapse or further relapse prevention. So during COVID-19 pandemic, in this diagrammatic representation, you can see that it had affected in various ways in the form of economic stress, the onset of psychopathology. To some people, it was new onset of psychopathology. For other group, like those people who already had pre-existing psychiatric illness, exacerbation of those psychological problems, loss of job, domestic violence, social isolation, and reduced availability of doctors or medical personnel in the addiction clinic. All these factors had a direct impact or direct correlation or association with substance use disorders and its various aspects, including withdrawal, tolerance, dependence, craving, and relapse. So here we are going to stick with two factors, that is craving and relapse. Now, because of new onset of psychopathology, loss of job, domestic violence, and reduced accessibility and availability of doctors or medical personnel from addiction centers, all those factors led to craving and leading to relapse. So we need to understand this correlation and how lockdown during this pandemic had direct correlation with relapse of substance use disorder. Now, when you see any relapse, we just don't have to see that when the person has taken, first drink. So relapse begins a way long before one picks up the drink. Gorky in 1982, along with Miller, published a paper, The Phases and Warning Signs of Relapse, in which they described Gorky's 37 warning signs and 10 phases that led up to an alcohol relapse. So we'll go through it one by one. Gorky had described 10 phases of relapse. The first phase being return of denial, which is concern about well-being and denial of the concern. Phase 2 is avoidance and defensive behavior, which comprises of believing I'll never use again, worrying about the others instead of self, defensiveness, compulsive and impulsive behavior, tendencies towards loneliness. Phase 3 is crisis building, where patient has tunnel vision, they have minor depressive features, loss of constructive planning, etc. Phase 4 is immobilization, where daydreaming, wishful thinking is the feeling that nothing can be solved, immature wish to be happy. Phase 5 is confusion and overreaction. There are periods of confusion, irritation, and anger outbursts seen in this phase. Phase 6 mainly comprises of depression or depressive features, which includes irregular eating habits, lack of desire to take action, irregular sleeping habits, loss of daily structure, periods of depression, deep depression, etc. Phase 7, where we see a behavioral loss of control, wherein you can see irregular attendance to meetings, development of I don't care kind of attitude, open rejection for help, dissatisfaction with life, feeling of powerless and helplessness. Phase 8, that is recognition of loss of control, self-pity, thoughts of social using, conscious lying, etc. Phase 9 is option reduction, unreasonable resentment, overwhelming loneliness, frustration, anger, and tension is seen. And finally comes acute relapse period, wherein loss of behavioral control and acute relapse is seen. So Gorky has described, all these 10 phases, that how relapse occurs, the event of relapse occurs. And we need to understand all these factors because there are subtle signs and symptoms. If you identify those subtle signs, it becomes easier for us to help patient, in time. Now there is another model of relapse prevention narrated by Marlet. The Marlet cognitive behavioral model of relapse is centered around detailed taxonomy of emotions, events, and situations that can precipitate both lapses and relapses for drinking. Now, this taxonomy includes both immediate relapse determinants and cohort antecedents, which indirectly increase a person's vulnerability to relapse. Now, both these classification of relapse determines the high-risk situations proposed in relapse prevention model. Allows us to think of numerous treatment options or components which we can develop, to help people recovering from these high-risk situations. Now, in this diagrammatic representation, you can see what are the immediate determinants of relapse. Now, whenever there are high-risk situations, there are situations like this COVID-19 pandemic. So, there could have been two types of reactions or responses from the people. Now, those people who have effectively cope up with their high risk situations or factors or psychosocial factors, it had increased their self-efficacy, leading to decreased probability of relapse. At the same time, though one group of people who could not able to cope up with those high-risk situations of COVID-19 pandemic, they had decreased self-efficacy, less of self-confidence, leading to initial lapse or initial use of alcohol, and then gradually leading to relapse. So this is one model of immediate determinants of relapse, which Marlet had described. Now, the another model is cohort antecedents of high risk situation. This diagram is very complicated, but I'll try to simplify it. There are several antecedents which has been explained by Marlet, right from lifestyle balance, desire for indulgence of the substance, urges and craving, rationalization and denial. And see, all these factors, they have direct correlation with high risk situations. And whenever these multiple factors, they come together, eventually leading to lapse and then relapse. So whenever we deal or whenever we try to evaluate any person who has high risk of relapse, we need to understand the psychosocial aspect or the stresses behind, or the contributing factors behind the behind the uh, behind the relapse. In patients with alcohol dependence syndrome in the recovery phase, we need to consider these two syndromes, that is pause and dry run syndrome. Pause is post-acute withdrawal syndrome, which can last from 6 months to 2 years after the stopping of alcohol. That includes variety of symptoms ranging from irritability, sleep troubles, and intermittent anxiety to prolonged depression. Sometimes it mimics immediate withdrawal. The symptoms involved in pause can be barrier for recovery. A dry trunk syndrome is an individual who is abstinent from alcohol but continues to act in much the same way when he was drinking alcohol. So these two syndromes we need to consider when we are dealing with relapse prevention, because these two syndromes require immediate medical management, because if we provide medical management to these patients, we may prevent relapse of these individuals. Now, in substance use treatment, the things which we need to consider is we have to think about the harm reduction strategies. We need to consider when an in-person visit is needed over telehealth visit or room-to-room telehealth. Social isolation is a risk factor for relapse. So virtual support meeting, whether it can be accessible to these patients, integrated behavioral health care, create a task force team to address their substance prevention, create a crisis response team as a wrap-around service, educate providers on substance use prevention, create positive messaging to prevent substance abuse, incorporate psychoeducation with treatment plan, allow providers to receive professional training or education to improve their treatment strategies, and incorporate other needs of assessment as well. NIMHANS had published certain guidelines in April 2020 for brief intervention for individuals with hazardous use of alcohol. See, this can help people who were in recovery phase and who had relapsed. So frames is a typical example of brief intervention for alcohol use. It can be provided in 5 to 15 minutes over 1 to 4 sessions, where F stands for feedback of personal risk, R stands for responsibility, A stands for advice, M stands for menu of alternate choices, E stands for express empathy, and S stands for self-efficacy. So if we advocate this intervention, we may reduce, the hazardous use of alcohol. Now, in relapse prevention, J. Krishnan Menon and Arun Andasamy had reviewed one article regarding relapse prevention, which comprises of cognitive behavioral model of relapse, which includes high-risk situation and covert antecedents, which we have explained in Marlet's cognitive behavioral model of relapse, abstinence violation effect, which refers to an individual's response to a relapse where often the patient blames himself or herself with subsequent loss of perceived control. Problem of immediate gratification. We have to think about, the relapse determinants, which are intrapersonal and interpersonal. Intrapersonal being self-efficacy, outcome expectancies, emotional states, coping, craving, motivation, etc. Where interpersonal determinants being positive social support. There is dynamic model of relapse prevention as well, where distal risk factors and proximal risk factors are assessed. A specific intervention strategies in relapse prevention being identifying and coping with high-risk situation, enhancing self-efficacy and cognitive restructuring. So with the help of these different models of relapse prevention, we can definitely help people with substance use disorder or alcohol dependence in recovery phase, we can prevent relapse by using these different models. Now we need to identify, certain personal triggers which they encounter. That is stress, emotional distress, other psychological problems ranging from anxiety, panic attack, depression, etc. Environmental cues that result in craving, relationship trouble, let it be in the form of domestic violence, job loss, or financial problems. So these are the common triggering factors which were noticed during this COVID-19 pandemic, or particularly in the lockdown period. Now, recognizing relapse warning signs. Now, how we can recognize the relapse warning signs? If the patient is returning to addictive thinking pattern, if he is engaging in compulsive self-defeating behaviors, if his thinking is rationally and if he is behaving less responsibly, if that person is finding, in a situation where drug or alcohol use seem like a logical escape from the pain, so they are trying to, use alcohol as a escape. So these are the certain warning signs which we need to consider. Now, there are some common ways to help people for the recovery. Now, we need to educate, patient on addiction and recovery. We need to make them understand and prepare for extended problems. We have to explain them for not, having unreasonable expectations, and how we can make changes to support their sobriety. We need to find self-help support, how we can reduce stresses and set and enforce boundaries for them. Now, there are some online sobriety support groups which were commonly used by alcohol dependent or substance use disorder patients, namely Alcohol Anonymous, self-management and recovery training, that is SMART, and other few examples where people could able to virtually meet, express and take support from other people recovering from alcohol use and preventing relapses. Now, the lesson which we have learned from this pandemic is As you all know, pandemic has brought a significant change in our daily living. The impact over physical, psychological, and social well-being. Social isolation being one of the major factors, and substance use disorder one of the vulnerable group which was affected during this period. And whatever psychosocial factors are possibly present for relapse, they were present together at a time during this pandemic. So we need to provide support instantaneously to these patients. Accessibility of doctors and de-addiction centers. We have to think regarding how we can enhance those access. Early intervention would definitely reduce the risk of relapse. Support and uninterrupted treatment through digital platform should be provided. So with this, if we have a holistic approach, I think so definitely we can prevent, relapse during this crisis situation. With this, I would stop my presentation. So thank you so much for patient listening.
Thank you, Dr. Chaugale, sir. It was a nice presentation. And all the three speakers spoke very well. Now we are on time. We have some questions in the question and answer box. We'll try to answer those questions. Then at the end of the session, I would like to request Dr. Bharat to conclude the session. Now the session is open for discussion. We have few questions in the question answer box. One question already answered live. And we have one question from Dr. Saranya Devanathan, past president IPS KC. Will add a caution like a cigarette package, that cigarette smoking is injurious to health, something like that, will prevent shopping food packets, will reduce these addictions. I request one of the panelists to answer the question.
Madam, that's a very nice question which has been asked. And actually, they have tried to do fMRI studies to see how does this cigarette packing images matter or not. Now, interestingly speaking, we expect as a public health policy that when you give literacy or when you give warnings, the behaviors might come down. But actually speaking, when they have tried to do fMRI studies in people who are aversive to the substance, for example, if I'm not a user and if I see the warning, I might actually detach from it and not use the substance. But in people who are so-called into dependence or addiction pattern already, their brains are a little different. Even when they see the warning, they don't get a trigger warning, but actually their craving cycles increase. So what happens is those people who are already into the process of addiction and those or in the little advanced stages, these warnings might not play any role at all. It might not deter them from it. Maybe the initial users or the users who are kind of experimenting and trying out, these warnings could play a role. This is the kind of conclusion which they have been able to make to some extent.
Can we write such warnings on the food packets like cigarette packets? Because food packet is meant for eating. And is it somewhere related to cigarette?
Interestingly speaking, sir, in FDA is coming up with some interesting warning samples like this drinks which are high caloric drinks like all your Pepsi, Coke, and those. They are wanting you not to just mention 360 grams or 200 grams and all because we don't understand what these grams mean. So they want you to have a packet where that much amount of sugar is actually shown along with it. So basically, they're trying to come with innovative ways of trying to make these people understand the real meaning of these ingredients. They're working on it. Definitely, all these things might work in the initial stages is what we need to understand. When we are thinking of a lot of alternatives and dietary changes and behavioral changes and those things, in those people, it can at least deter the initiation of a whole addictive cycle. It has its own, that's where innovative labeling and innovative warning is the way to go. But most of the time, these are very preventive steps, not in advanced cases. In advanced scenarios, the more complex strategies have to be worked upon.
Fine. Thank you, sir. Now, Dr. Swaminathan, sir, has got some reservation on internet addiction, whether that behavior is really an addiction. If I think if Dr. Swaminathan, sir, is there, kindly unmute and you can speak for 1 minute or so that we can clarify. And I think that will be a final question.
Seeing him. This version, a few years have passed by, and Devaki not only wishes to see her son, but also wishes to be free from her pitiful state.
I think there is some trouble with the correction. So he says the intensity of craving in gaming disorders seem to be more than the other disorders. I get overwhelmed by the intense emotions in both the patient as well as family, which is much less than other disorders. Just offered a child addicted to PUBG on request by parent, which usually I would have handled in other addictions. I think internet-based addictions are seen more in more persons who are otherwise successful in their areas of expertise. It's a less probable of identification and more culturally accepted. I think that's a comment. It's not a question.
Yeah, I completely agree with that. Internet itself is not considered as an addiction, actually. Internet is a means. It's a means to go for pornography. It may be for gambling. It's for gaming. See, earlier, in the absence of internet, a person whose brain is weak or whose dopamine release or reward deficiency syndrome is there, he need to go outside and seek drug. Now it has entered into the bedroom. That is through internet. So he need not go and seek drugs. He can substitute drugs with the internet, or what we call it as whatever other things what he's doing, gaming, gambling, all those things. So that means access has increased to various means of for addiction. It may be even shopping also. So here calling internet addiction is a means rather than anything else. It's even the earlier question also asked about the food. Food can be addiction. Of course, if you look at the criteria, food meets all the criteria for addiction. But however, anything, it has to be in moderation. So that is the way. Even if I remember, Professor R.S. Pandey sir had given 1 hour talk on food as an addiction. So it's an amazing discussion actually on that area. But however, naming internet addiction, it's quite different things, because people use internet for various reasons and also various means of addiction may occur. So I would like to ask Dr. Sunil Mohan on this issue, whether would you like to call it as an internet addiction, or would you like to consider it as a different entity? Today maybe PUBG, maybe other game, or shopping, gaming, maybe anything.
Sir, I think Dr. Anil pointed out, gaming itself is a very complex process, and each one plays games for different reasons. Like I also mentioned in one of the slides, different types of gamers are there. A few interesting points is not all users of internet are called to be addicted, or not all of them become addicted at all. In fact, a lot of us use internet left, right, and center day in and day out, but we might not be so-called misusing it to a significant extent. Like we know there are people who socially drink alcohol and those things, so we don't call them into the bandwagon of substance use addiction. So the same things are looked at. But in behavioral addiction, whether we are talking about food or even internet, I think the parameters which are looked at is almost similar, where the disability caused by that, like for example, if I'm sitting and gaming for hours together, not taking care of my physical health or mental health, or not doing other important things which I'm supposed to do, like my assignment, submission, and those, then you need to look at where very interestingly point out anything which is excessive to the extent that it reduces your overall life quality, then you need to look at whether it is an addictive pattern or not. Now, whether you call it as addiction or like substance use disorder has become more viable term now rather than substance addiction and those. So like that, internet use disorder and those kind of concepts are also being discussed. So I guess the disability cost, the secondary dysfunctionality cost has to be evaluated, not just hours on internet or hours on Facebook or social media. So getting into those specific parameters, like what we do in addiction, is what the clinicians have to look at to say whether they have any behavioral addictive properties and whether they've developed, and also ask them why are they spending so much time on that. That is going to give us an idea of why that specific individual
The
is
issue was whether should we call it as internet, like we call it as substance dependence. Okay, can we call it as virtual dependence? No, I'm just debating, because the issue of whether should we call it as internet dependence, it is the nomenclature. We know the disability and those aspects which we have presented very well, both yourself and Anil, and also the Nikhil. But the question is whether should we call it as internet addiction or internet dependence, or it should be virtual. The naming, because it's a means, like substance is also a means, a kind of, but there are many substances, or maybe alcohol, cocaine, opioid. Should we call it as substance dependence, similar to that virtual dependence, or should we call it as internet dependence? That is the wording. It's basically nomenclature, what Dr. Swami sir has asked. I think Dr. Shripati Bhatt sir has raised his hand. Dr. Shripati Bhatt sir, can you unmute and ask your question, sir?
We can't hear you properly, sir. Kindly.
Can you?
Yeah.
Please go ahead, sir.
See, I have some patients, especially student population, who have substance use or any of these addictions. And they come and tell me that I know it is due to dopaminergic system, which is there in my brain. And they even say maybe it is in frontal lobe dopaminergic system. And I want you to give me drugs that block it, or that whatever it is. And they easily put the blame onto the neurotransmitter, and ball is in your court, you don't know how to hit it. I don't know what is the answer for it. Because this, whatever that has been discussed today, is very much available in the internet for most of the youngsters who are in addiction. In fact, I would say one of the signs of addiction is a person who is using some behavior or substance and trying to look for, various things about it on Google. That is the first sign of addiction itself. And there are people who are like that. What do we tell them?
Dr. Anil, would you like to respond?
Yeah, I mean, I agree with the sir's point. The issue, for the same reason, it is still not as a ICD or a DSM diagnosis. It is still under debate whether we should have it as a diagnosis. So it is not an approved diagnosis. I agree with sir, there are arguments for and against whether we should include or not include. And the possible explanation or diagnosis also says that it should be clinically significant or should cause significant dysfunction to the person. So someone just using we need not call it as a addiction. So it should cause clinically or a social dysfunction for the person. And what we are discussing is still not a diagnosis. It's still under debate. So we don't know whether it will actually become a diagnosis. But then what we know is it is causing a lot of dysfunction and affecting a lot of people.
Nikhil, Dr. Shripati Bhatt sir has asked about the intervention. What should we say to our kids who are internet addicted, and these whatever we discussed is available? Is there any medications? Can we give medicine and say, yes, this medicine will block?
First of all, whenever we are dealing internet addiction or behavioral addiction, in particularly children or adolescent, we have to restrict ourselves, giving medications. That's what, I feel. We need to find it out, because for probably last 3 to 4 months, I think so, all the kids, they are using internet, they are using rest of the platforms to, attend the schools. So we cannot, it's very difficult to say that whether we need to restrict them for, using smartphones, using internet. Behavioral modifications or some kind of therapies or counseling, even parental guidance definitely would help them, right, rather than just giving them medications and medicines. So my opinion is that we need not have to rush prescribing medicines to kids or children unless they exhibit any gross behavioral disturbances or impulsive behavior.
Okay. Dr. Sunil, would you like to add anything about this? Medications or intervention? Like many of our patients, family members, or somebody will come and say, my kids are now engaged in it, and they also know that it is creating trouble to them. Now they have come in front of you. What would you like to do? It's like more of only CBT, or would you like to give medicines? What does the current literature says, Dr. Sunil?
Sir, I think definitely medications can have its own role to play, especially two very common things which we miss in this young population is the social anxiety and depression. Of course, depression many times, yeah, especially depression and social anxiety. If you seriously look at people who are using internet a lot, you will find a lot of them. In fact, one of the trends we have seen, which I think will be very useful for all of us to know, is because in Bangalore, what happens is a lot of people finish their 12th and go abroad to study. We have seen a lot of good students finish their 12th here with good grades, are put abroad to study in new schools and colleges. Now, when they go there, they start using substances more, or maybe they've got introduced and getting into cannabis use, especially, which has significant usage outside, and they get access and all. So, what has been noticed in them is they would have had social anxiety here itself. So, when they go there, the cultural shock and so many other things and the substance use gets them to deteriorate very significantly, and they lose a year and come back. And most of the times we realize they are brought to us telling he's using too much gadget, but gadget use is current problem, but we find social anxiety was way much there about 2-3 years before itself. So self-esteem issues and so many things comes up. So I guess it is important, like Dr. Sripati sir mentioned, if they bring in some theories according to them telling dopamine is the problem or this chemical is the problem, I think that theory could also have its validity, but we also need to put across telling there are multiple paths which could be interfering. So we'll work on this path as well as the rest of the path and kind of get them into confidence and work towards. If we say that we need some time to understand and work towards a multi-pronged approach, some people, at least who are very much motivated, give us enough time to work on, and we should be able to make inroads with a combination of biopsychosocial interventions together.
Yeah, I think the two important points to take away by Dr. Sripati Bhatt's question. First and the foremost is we have a role to play, especially if there are comorbidities. Look for the comorbidity, anxiety disorder, and also the depression. Other drug abuse may be concurrent, may be there. So that is the second thing we have to look into it. Third, of course, the issue, the way we are going to give the model. Like I was working in OCD clinic for nearly 15 to 20 years, 16 years I was there in OCD clinic. The commonest question is, sir, you mentioned that there is decreased SSRI, give me medicine, fill my tank, SSRI tank in my brain. That is the way they used to say. Then one of the way we learn to answer them is, yes, we have put the petrol into your tank SSRI by giving medicine, but the vehicle doesn't run. You have to kick start. You have to ride the vehicle. Vehicle will not run on its own. So that is the model we used to say. So definitely we have a role to play from comorbidity angle. And definitely if there is a comorbidity present, please do treat them. Of course, internet addiction, again, these addiction, behavioral addiction, the definition, how do we define? On that basis, the prevalence is there. If you look at the literature, it starts from 4% to 60%, the prevalence of internet addiction or problematic users. Similarly, if you look at the substance abuse, like out of 6, there should be 3 in the past 6 months or 1 year. That is the way ICD-10 qualifies for substance abuse. Here, how many criteria should be there, for how long, those are not yet been defined. So depending upon that, we have to take it. But at this point of time, we have to keep it as a, if there is a problem which is coming in the way all the 3 panelists beautifully said, if it comes in the way of their socio, biological and occupational functioning, definitely we have to interfere. Sir, Arish sir, would you like to take the next questions?
No questions. now it is a time for us. I think I appreciate the presence of Dr. Madhukar sir, the immediate past president. Dr. Sripati Bhatt is ready for valedictory function. So shall we conclude? It's time, I think. So I immensely thank all the speakers for the wonderful presentation. And I also thank Dr. Badamat sir for being with me. So thank you all. So let us move on to our next program, the valedictory function. Thank you one and all.
Thank you.
Thank you, sir. Thank you, Dr. Delanta Bettu and Dr. Suresh Paramat for excellently having your presence, and all the speakers to have provided us a scientific feast. And we are quite well on the time, and we'll proceed to valedictory function. And for the information, the valedictory function will not be held on this link, and the new link has been shared over all the platforms, WhatsApp groups and IPSKC Yahoo groups. So kindly log out from this link and re-log in to the valedictory function, which will be starting soon. I thank you one and all.
Thank you.
Thank you one and all.
Thank you.